Welcome from the Bombay Seaboard Medical Association, Bombay Medical Union, and HN Reliance Foundation Hospital, along with GPA, Federation of Family Physicians Association of India, D-Ward Medical Association, A-Ward Medical Association, Jain Doctors Federation. Today we have one more association joining us, that is Midtown Medicos. We welcome you also. Adhering to our aims and objectives of providing high standard of educational activity to family physicians, ours was the first association to start webinar during this lockdown. Except for the month of April, we have continued holding it on the first Sunday of every month as per our tradition. All this is possible due to the efforts of our scientific committee chairman, Dr. Anil Mehta, and his team, and constant support of office bearers of other associations. Today's webinar is also one of the first to be granted one MMC accreditation credit point from case-to-case category after lockdown. And I would like to welcome Dr. Suresh Doshi, who is observer for today's webinar. I would like to welcome today's speakers, who are one of the best in the field. Dr. Mahesh Balsekar, who will talk on well child care and screening protocols in children. Dr. Rahul Verma, who is going to speak first, will speak on an approach to a child with abnormal movement. Dr. Rasik Shah will speak on spot bedside diagnosis in surgical pediatrics. And Dr. Pankaj Parekh will appraise us on A to Z of vaccination in question and answer form. I welcome you all and request Dr. Anil Mehta to carry forward and proceed with our agenda.
Good morning, all. Thank you, Dr. Khambati, and a warm welcome to our CME feast on the first Sundays of every month. The ever-growing enthusiasm amongst the participating associations and the ever-growing numbers of the delegates, they encourage us to take the CME to a very different level. I really thank all to help me out to do so. And pediatrics will always remain the part of family practice. May it be right from the some medico-surgical emergency in your clinic setting or vaccinations, so on and so forth. We have been serving children and it will continue to go on so. So today we have tried and to put it up like the renowned pediatricians presenting a very power-packed pictorial session with lots of carry-home messages. It will refresh our pediatric knowledge, and always and above all, we have now one MMC credit point to this, so that will be an additional feather in the cap. One more announcement before we start. Now we are in the 7th month of COVID pandemic, and there is a great demand and need for home management of mild to moderate COVID affected patients. And as we all know that the family physician still remains the backbone of this entire pandemic. So we have to update this on do's and don'ts. We have a webinar on home management of COVID-19 patients on this coming Friday, on 9th October between 3:30 to 5 p.m. The speaker will be none other than Rasik Shah, an avid teacher and a corona warrior. So now we start today's program. Over to Dr. Jawahar Mukherjee.
Hello everyone, good morning. Today we shall be starting first with Dr. Rahul Verma, who shall be speaking on approach to a child with abnormal movements. To introduce Dr. Rahul Verma, I shall call upon Dr. Rajkishore Bajpai from the FFPAI and our friends and esteemed colleagues, Dr. Janak Shah, Dr. Rohit Jariwala, and Dr. Shrikant Rao to accompany him for the question and answer sessions later. Thank you.
We are sharing Dr. Balsekar's screen, Jawahar.
Yeah, but Dr. Rahul Verma is supposed to start first. Are you Dr. Balsekar starting?
No, but the screen is of Dr. Balsekar. So,
yeah, Dr. Verma to please share the screen.
Please. May I speak? Hello?
Yes, sir.
Hello.
Yes, sir. Yes, sir.
Yeah.
Yes, okay. Hello, friends. Good morning to all of you. Today's first speaker is Dr. Rahul Verma. He has got 25 years of experience in the field of pediatrics and in neonatology. He did his MBBS, MD, DCH, MRCP UK. Dr. Rahul Verma is the Director of Pediatrics Science at Sir H. He is basically a neonatologist, but does indulges in the some pediatrician also. He did his MBBS from the University of Mumbai. Then he did his DCH from the College of Physicians and Surgeons, Mumbai. Thereafter, he did MD and further went to complete his MRCP from Royal College of Physicians, UK. Dr. Verma is a leading pediatrician, has several publications to his credit. He has been a student pediatrics in Bombay Hospital for several years, and he has given his services to Oakats and Seven Hills Hospital also. He is a life member of the National Neonatological Forum of India, life member of Mumbai branch of Indian Academy of Pediatrics, visiting scholar, Babies and Children Hospital, Columbia, Presbyterian Group of Hospitals, New York, USA, visiting fellow, Regional Neonatal Reference Unit, King's College Hospital, London, UK, Joint Secretary and Treasurer of Maharashtra Chapter, NNF, Joint Secretary of NNF Mumbai, Currency Executive Committee member, Secretary NNF Mumbai, Secretary Neonatal Forum, and so many associations he is involved himself, and he is a very great and renowned politician of India, and his subject is an approach to a child with abnormal movements. To Rahul Verma, please enlighten us from your knowledge to us. Thank you.
Thank you very much. I just hope that my lecture is going to be longer than the exaggerated introduction that I've got. Kind words, but I think too many of them. Anyway, going on to the topic of the day, which is an approach to a child with abnormal movements. So it does become an issue because, as you rightly said, I'm primarily a neonatologist. And this is what I see actually in my NICU, and I'm very comfortable to talk about such situations. However, looking at the topic of the day, this is not what I'm going to talk today. So basically, we will discuss or talk about abnormal movement disorders in children. So this is a diverse class of clinical conditions that result in involuntary movements or impaired motor ability that can be immensely disabling, very disturbing to a child. Initially, the child may not understand the situation, but as the child keeps on growing up, developing and maturing, he does understand that this can be an object of ridicule and this can take a huge stress on him. So that is why we need to identify what is going on and make the appropriate referral once we are sure that whatever the child is exhibiting is not a normal movement. So these movements include multiple things like dystonia, spasticity, ataxia, chorea, Parkinsonism, much more common in adults, but also occasionally seen in children, myoclonic movements, tic disorders. So there's so many of them. And most of them can be attributed to preferably do not know the etiology. A few of them can be attributed to primary genetic conditions, to also ischemic injury, which is most commonly seen at birth. And of course, the second largest chunk of ischemia is post-viral meningoencephalitis or even bacterial encephalitis. So there are multiple issues over here, and things are not always transparent as to what the cause of these abnormal movements are. However, we can definitely make an attempt, and hopefully we should be able to come to some diagnosis. So it's very critical to identify and treat motor symptoms in children at an early stage, as I said, to prevent further embarrassment and stress on the child, not only physically, but also psychological stress. So this is, in a way, all the possible movement disorders in children. So it can be cerebral palsy. The cerebral palsy itself can lead to tremors, ataxia, chorea, spasticity, dystonia, myoclonus, and rarely Parkinsonism. And on the other side, you have obsessive compulsive disorders, ADHD, Gilles-Della, Tourette syndrome, and tics. So this is a huge basket, and this is still not complete. There are many more other disorders which are not included in this graph. And we'll try to see if we can actually discuss the basic movement disorders noted in children. So to understand the types of movement disorders, we need to practically break it up into hyperkinetic movement disorders. These are basically abnormal, repetitive, involuntary movements. So these are excessive movements which are noted. And this set of disorders are much more commonly seen in children. These include tics, chorea, ballismic movements, dystonia, myoclonus, stereotyped movements, and tremors. Once again, I would like to emphasize, I am not talking about convulsions. That is a whole section in itself. As a matter of fact, each topic here, each cause is a separate section, but we'll try to superficially go through and at least try to recognize this abnormal movement. So besides the hyperkinetic movement disorders, we have hypokinetic movement disorders. And these are very uncommon in children, not absent, but uncommon. And Parkinsonism is one of the commonest diseases which cause hypokinetic movement disorder. So let us try to take the next step. So to understand this, we do what is known as a phenomenologic classification or a physical classification. That means a movement classification. So on the left-hand side of this table, you will see the movement disorder. So there are tics, chorea, ballismus, dystonia, myoclonus, stereotypy, tremor, and Parkinsonism. And we will attempt to briefly describe each movement disorder. So tics are basically stereotyped. That means they move in the same way each time. Intermittent, sudden, discrete, repetitive, non-rhythmic movements, most frequently involving the upper torso, so head and the upper body. On the other hand, chorea is actually a chaotic, random, repetitive, brief, purposeful set of movements. They are rapid, but they are not as rapid as myoclonus. So when of very large amplitude, someone's duplicating their screen. That is why you're getting an echo over there, please. So when they're of a very large amplitude, that means huge movements, then these choric limb movements are often termed as ballismus. Then the third part is dystonia, which is repetitive, sustained, abnormal posturing, and actually surprisingly a paucity of movement. So there is actually a limited movement because of an abnormal balance between the pro and the anti set of muscles. And these abnormal postures typically have a very twisting quality, and they're quite uncontrollable for the child. Then we have myoclonus. They're shock-like movements. They can be repetitive or rhythmic, and we will talk a bit more if we have the chance. Stereotypic movements are usually patterned, episodic, repetitive, purposeless movements, and they are still rhythmic in nature. Tremors are, of course, rhythmic oscillation about a central point or position involving one or more body parts. And of course, Parkinsonism, which, to be honest, I have never seen in childhood. I'm sure there will be some pediatricians who probably have seen them. And these are hypokinetic syndromes characterized by a rest tremor, slow movement, which we call bradykinesia, rigidity, and postural instability. So in a nutshell, these are the abnormal movements which we try to attempt to classify and define in children. Let's try to take each one at a time. So I have tics, which are stereotyped, intermittent, sudden, discrete, repetitive. If I can show you on this video, you see this child is actually just dancing away, or this child, or so this is one way of moving. On the other hand, I have this child who will have rapid blinking movements. Okay, So these are all tics. They do not seem to have a definitive organic cause, but they are more habitual rather than organic. So, sorry, going back. So you can have transient tics, you may have chronic tics, or you may have the classical Tourette syndrome, or also known as Gilles-de-la-Tourette syndrome, where you have tics associated with sometimes usage of foul language, and of course, some amount of developmental issues. So these are the tics which we commonly see. When we try to define Tourette syndrome, basically these are chronic tics. Usually onset is prior to 18 years of age and definitely requires serious intervention. And behavioral therapy seems to work very well in such children. To define these tics can be further motor, which means just abnormal rapid movements of the limb or of the eyes, or they can be vocal, where you can have so the child actually is almost wrapping himself without realizing it. And then you may have acute, that is short duration transient tics, or you may have chronic tic disorders, which is more than 1 year of age, more commonly seen with motor tics rather than with vocal tics. I've already spoken about the Gilles-de-la-Tourette syndrome. So this is the first abnormal movement that you can see. Once again, I think this would be the commonest, as I said, video presentation of a tic. And of course, this would be the other one who comes in. As you can see, the eye movements go really vague. Okay, and most of the time, these children do not realize it. Okay. Next movement disorder we come to is chorea. Now, chorea is actually a frequent, brief, unpredictable. That means there is no stereotypy over here. Purposeless movement, which is actually almost a continuous movement flowing from one part of the body to another. And it is very unpredictable in which direction it will move. There are multiple causes of chorea. You can have metabolic causes. One of the important causes, as far as I am concerned, is perinatal HIE. Of course, you can have post-infectious, and of which rheumatic fever once upon a time used to be a very, very important cause of chorea, which was also known as Sydenham's chorea. Nowadays, viral encephalitis, other vascular events, some toxins and some genetic disorders can also present as chorea. Most of the chorea in childhood is secondary. Primary chorea is extremely unusual in childhood. And till recently, the commonest cause of chorea was acute rheumatic fever, usually seen between 5 to 15 years. Girls were more affected once you cross 10 years of age, and they were associated behavioral disorders. So if I can show you what is a chorea movement like. This child is lying down and you can see the gradual movement coming in first in the hands, and then they will move across anywhere without being able to predict which direction they are going to go. Suddenly the leg starts moving, but they are continuous and they move in slow motion, and they are very smooth, and they will go to different body parts. So even when this child is walking, you will suddenly realize the flinging of the hand behind his back. If you go to see, there you are. So that is there, and they try to then hide it with a quasi-purposeful movement. That means in an attempt to show that they're actually attempting something voluntarily rather than having an involuntary movement. So this is chorea, and as you can see, we still have rheumatic fever as probably the single most important cause, but now we've got other etiologies which we need to look out for, since rheumatic fever is not very common in childhood nowadays, hopefully. The next movement disorder we come to is dystonia. And dystonia basically is a sustained muscle contraction causing twisting and repetitive movements or abnormal posturing. So as you can see the photo, the child in the right-hand side, and you can see the right hand has gone into an abnormal posture, the left hand has gone into an abnormal posture, and this child has trouble in trying to control her movements at all. The important thing to understand is that these dystonic movements actually disappear in sleep. Somehow, once you have the upper control going off to sleep, automatically these dystonic movements tend to disappear. So you can have dystonia in childhood or you can have dystonia in the adults. Primary causes exist, which is idiopathic, not very common in children. And the commonest primary cause will be a DOPA-responsive dystonia and responds dramatically to low doses of levodopa. Secondary causes exist, and of course, we can try to classify them according to the movement of a particular or more parts of the body. So they can be focal, segmental, multifocal, half a body going dystonic, and a generalized dystonia. As far as I am concerned, for me, the commonest cause of dystonia would probably be perinatal hypoxia or perinatal asphyxia, or what we call today as HIE. And this is something I need to follow up in my children with birth asphyxia once I've labeled them as perinatal hypoxia and ensure that they do not land up, or if they do land up, then we treat them early. There are other causes associated with syndromes, ataxia, telangiectasia, Lesch-Nyhan syndrome, you have mitochondrial disorder. These are very rare syndromes. So it is recommended that these children be referred to a specialist as soon as possible once we believe that this child has dystonic movements. Then we come to the next movement disorder, which is myoclonus. Now, myoclonus is a brief, abrupt, involuntary, non-suppressible. That means if you hold down the child will still move and have jerky contractions. It's almost a shock-like situation. So it just briefly comes and goes. We used to also call some of these infants with myoclonic convulsions as having salam attacks, and you can easily see how that happens. These myoclonic movements can be focal, multifocal. It can be in a certain area like the right upper a limb, or they can be generalized. They can be elicited by sensory stimulus. So if you clap loudly or make a loud noise, you will realize that the myoclonus gets exaggerated. And any child who is thought to have myoclonus mandatorily should be evaluated by a proper neurologist. So you can see this child, he just suddenly moves. It's a child of HIE. He obviously doesn't understand what's happening. But as you can see, these sudden movements of more than one part, it's almost as if he's got a left-sided myoclonus. He has a vague, blank smile, not aware of what is happening around, and this is classical myoclonus you see associated with neurodegenerative or with static lesions like hypoxic ischemic encephalopathy. Okay? So this is a combination of both. Right. So the next disorder are stereotypic movements. Now, these are very vague disorders, may not always have an organic cause, and actually are quite benign. So they're intermittent, involuntary, repetitive, purposeless movements, and they're quite patterned and usually rhythmic. So arm flapping, rocking, licking, mouth opening, hand waving. We see these with children with CNS abnormalities. In their own, they are not at all harmful or do not merit direct treatment. What we need to do is treat the cause. And so the commonly associated issues are with mental retardation, autism, Rett syndrome, blindness, and very rarely seen in normal children. So they usually begin in infancy quite early, but unlike tics, tend not to change in type or time. So they more or less will remain the same. These stereotypic movements remain the same over years, unlike tics which keep on changing from one type to another. And they usually will stop. These stereotypic movements will stop if the child is distracted. So telling him, asking him to watch a movie suddenly will make him stop his stereotypic movements. Once again, they are not very easily picked up because many of the movements are considered to be normal in children and hence merit some amount of observation before you can label a child with stereotypic movement. Tremors, everyone is aware of tremors. Most of you all would be aware because you'll have seen tremors in old age, which is physiological, and you see it in Parkinsonism. There are a lot of other adult diseases where you see tremors. But in childhood, they can be classified as tremors at rest, tremors with intention, or action tremors. Rest tremor is defined as tremor which is involving an inactive body part, and it is supported against gravity. That means the muscle is relaxed. It is commonly associated with Parkinsonism and, of course, temporarily seen with antipsychotic medications. Intention tremor is when you want to make a movement. So like doing a nose finger test, as you approach the target, you really start having a lot of tremors, and it is commonly seen with cerebellar dysfunction. Action tremors occur during maintained posture or voluntary movement or both. So there's a slight difference between intention tremor and action tremor. Now, when tremor is the only abnormality, it is important to identify the potential tremor and enhancing medication. There may be some medication which cause more tremors, and we need to keep that in mind. If I give salbutamol to a child too often, I will start seeing tremors in that child. One of the important things to rule out and completely treatable and important to figure out is a thyroid abnormality, which is commonly seen with tremors. So any child with tremors should have a screening T3, T4, TSH, FT4 done to rule out any thyroid abnormalities. So the last bit which I come to is drug-induced abnormal movements. Now, we are aware that we have a lot of drugs which we use, and I think we should be aware the commonest for us is metoclopramide, and that is one of the reasons we do not use Perinom anymore in children, because it causes what is known as an oculogyric crisis, responds well to antihistaminics, and is completely reversible. There are other medications like antiepileptics or beta agonists, drugs, I mean actual drugs, the ones which the affluent people take, amphetamines, cocaine, all of these can also cause chorea and tremors, and I think we need to be aware of these. Last 1 or 2 slides. So the basic question to ask when you have a child whom you think has an abnormal movement would be, is the pattern of movement normal or abnormal? That is the first question. Are the movements in excess, which is hyperkinetic, or they are diminished, which is hypokinetic? Is the movement paroxysmal, sudden onset, offset, continual? It's a continuous writhing movement, not sure which way it's going, or continuous without stopping or recurring? Has the movement disorder changed over time? Do environmental stimuli or emotional states modulate? So if I clap my hand suddenly and I have a sudden jerky movement, then is there a challenge, and is this movement a myoclonic disorder? Can the movements be suppressed voluntarily? Can you hold them down, which would probably be tics? Is the abnormal movement heralded by a premonitory sensation on urge? Do you have a sort of a deja vu prior to this abnormal movement? Are there abnormal findings on examination suggesting of a neurological disorder or any other systemic disorders? SLE in adolescence is a very common reason for tremors in childhood. Is there a family history? If you're talking genetic or a primary cause, then family history becomes very similar in older sibs or mother or father. And does the movement disappear when the child is asleep? So these are the basic questions, and I've already covered these points in the individual movement. So last thing is we have various modalities of treatment. There's surgical treatment, medical treatment, and of course behavioral therapy. And I think that becomes very important in most of the abnormal movements besides myoclonic or dystonia. All the others, especially Guillain-Barré, Tourette, tics, tremors, which are non-organic, or any other such similar disorders, will easily respond to specific therapies rather than medication. Rarely we may have to do deep brain stimulation as a surgical therapy. Those are more for severe organic disorders. So with this, I end a quote from Benjamin Franklin that the eye of the master, what we see, will do more work than just examining the patient with your hands. Thank you. I am trying to stop.
Dr. Rahul Verma.
Yes.
Sir, congratulations. It is a wonderful session, sir. Very, very pictorial. Your video clippings, your description, the whole topic of abnormal movements you have covered in a shortest possible time. That was really great and wonderful to listen to you, sir. I am Dr. Srikant Rao from Bangalore. I want to ask one or two small things, sir. See, there are many children who come with some occasional abnormal movement during sleep, here and there. It does not really bother them, does not during sleep or when they wake up from sleep, and it doesn't continue. I just want to know from you, do you have the line of demarcation? This is normal, this is abnormal. This thing needs a neurology referral, this needs a workup, whereas this doesn't need. And another thing is, I want to know, what about the cognitive impairment also along with these abnormal movements to some of these children? Because that is a matter of great concern. If it is only motor activity, abnormal movement is fine. If it is a brain damage and developmental problem, that becomes a big issue. Can you throw some light on this? When to refer to neurologist or to you? What is normal? What is abnormal? Throw some light, sir.
So one of the most important thing is the moment a parent brings a child to you, stating that I am worried my child is making abnormal movements, itself raises a red flag, because if the parents are concerned, and obviously it is stressing them out whether the child is doing this too frequently, which is an important aspect, or the other people in the society are pointing out that this is not normal. So I think it's very important to understand that the fact that the parent himself or herself has got the child to you definitely merits an exploration and evaluation of whether this movement is normal or abnormal. I think experience probably is the single most important thing which decides whether we can hold on or whether this child will merit further investigations. Scholastic and cognitive dysfunction is very commonly seen, as I said, whether you have chorea, whether you have myoclonus. The cause of the abnormal movement itself is going to be a challenge for scholastic achievement. So if I have a child with a history of perinatal asphyxia, and at the age of 1 year is having a problem walking because his whole body contorts into a dystonic posture, obviously this is going to create a problem. And we do need to understand that those cerebral palsy, which is one of the secondary causes of abnormal movements, usually they have a physical limitation. However, the physical frustration of not being able to communicate in these issues, as well as a genuine effect of the mental status, both of these will definitely affect the child's neurodevelopment. So I think that is
what is the long-term prognosis of these kids, like dystonia, or chorea, or athetosis, hemibalismus?
All these movement disorders, they have an underlying cause, most of them. So if I attempt to treat the underlying cause, the commonest thing I will give you, the simplest thing is using perinom in children. And you have an oculogyric crisis. For half an hour, the child is looking up towards the heavens, having abnormal dystonic posturing, severe extension of the head. And the moment you give phenargan or diphenhydramine or something like that, and the child appears normal, it shows that we have treated the primary cause. We have not treated the movement abnormality. If I have a child with, say, cerebral palsy, this is much more of a challenge, because the brain has already been affected, and reversing such a situation is going to be very difficult. So in that situation, we can try to bring the child as normal as possible without being able to promise that this child will remain entirely normal. So we have behavioral therapies. For tics, we have behavioral therapies. If you have Guillain-Barré, I think a lot of behavioral therapies, some amount of medication will bring about relief from these abnormal movements. But I think you have to take it on each and every movement disorder, and more importantly, the cause behind the movement disorder, to assess whether we'll be able to A, completely define, B, control, and C, possibly treat the movement disorder.
And how long does the follow-up continue? Years together, how long does it continue?
So if it is something like, say, I mean, I've not seen rheumatic fever for a long time, but we usually follow them up for 6 months to 1 year to see how they're doing with chorea. But then if I have a child who's had a perinatal insult, or has a syndrome, or has a genetic single gene defect, even an enzyme defect, I think these children merit follow-up forever, because I don't think we can leave them alone. And they require support at every, you may not treat them, but they will require physical and social support at every stage to maintain as near education as possible.
Thank you, sir. Thank you.
Dr. Rahul Verma, my question to you is, it's a simple question. You spoke about the drug-induced involuntary movements.
Sorry, can I interrupt, please? Can I interrupt? We are going to have a question and answer session at the end of both the speakers. So I think we will go to the second speaker and then we'll come back to the question and answers.
Thank you.
Thank you so much. Can I invite Dr. Nisha Kushlani, my colleagues from the A ward, and Dr. Cyrus Mehta. Dr. Nisha Kushlani will introduce Dr. Mahesh Balsekar for the next topic. Dr. Kushlani, please.
Yeah. Good morning. Can everyone hear me clearly?
Yeah.
Hello.
Yeah. Yes.
Good morning, respected seniors, colleagues, and friends. It's a great privilege and honor for me to be introducing Dr. Mahesh Balsekar, sir, today. And just a brief introduction first. Sir has been in practice since 1985 and has been associated with several leading hospitals in Mumbai. He has trained at the Wadia Children's Hospital and the Seth GS Medical College and KM Hospital. He was a rank holder in the DCH and MD examinations. Dr. Mahesh Balsekar is a consultant at the Pediatrics Department at the Sir H.N.'s Reliance Hospital Foundation and Research Center. His areas of interest includes neonatology as well. He has spoken at several national and international conferences and has numerous publications to his credit. He has a special interest in social medicine and is the founder of a charitable trust called Healing Touch, is also on the advisory board of St. Jude's and Project Needs. I only regret is it's a virtual webinar and not an actual one, where we could welcome sir with a thunderous round of applause. But nevertheless, these are COVID times. Over to you, sir. Welcome.
Thank you. Can you hear me? Is everything okay?
Yeah, loud and clear.
So thank you for inviting me. You can go. No, it's okay. Yeah. Thank you for inviting me, Dr. Anil and Dr. Khambati and Dr. Jawahar Mukhtiar. I'm going to be talking about preventive pediatrics today. And the first half of 10 minutes, I'll be speaking on health supervision of children. And the second half, I'll talk about screening tests in pediatrics. Health supervision of children is extremely important, and almost a third of our general pediatric practice involves routine care of healthy children. In infants, this means generally a well child visit. Older children normally come for an annual health check, but we should not forget that even when a child comes for a sick child visit, we have to look after the general health and not only treat the illness for which the child has come. Now, the most important slide here today is that an immunization visit is a misnomer. When a patient comes to you for an immunization, we are supposed to do all these things mentioned here, which includes growth monitoring, nutritional assessment and counseling, a developmental assessment, anticipatory guidance, where parents may not ask questions, but it is our obligation to go through behavior problems, accident prevention, whether the child is sleeping probably, and lifestyle issues. And last, we go for immunization. And before that, and before we end, we must always give the parents an opportunity to ask questions for any concerns that they have. Because the one grievance all parents have is that they don't get enough time to ask questions. Growth monitoring is a very important part of health supervision. For 0 to 5 years, we normally use the WHO charts, and after 5 years, we use the IAP or the Indian Academy of Pediatrics charts. This includes weight, length, head circumference, and we take weight for length and BMI to see whether the child is overweight. One recommendation is that all of you must download the Indian Academy of Pediatrics growth chart. It's a wonderful site, free, and the moment you enter the child's weight and length and the parent's height and weight, it gives you the percentiles for height, weight, and BMI, and at a glance you know whether the child is growing well. It's an extremely useful chart. Now, when you talk about the weight measurement, it decelerates over a period of time. And in the first 3 months, infants gain 200. Next 3 months, it's 150 grams per week, then 100 grams and 50 to 75 grams between 9 and 12 months. In the second year, they gain 2.5. Beyond the age of 2 years, till adolescence, the normal weight gain is 2 kilos per year. This is very important because one of the common visits to a pediatrician is the concern that a child is not eating well and not growing well. So the child is gaining 2 kilos per year, then generally that is reassuring. Now, when you take the length or height of a child till the age of 2 years, we have to take recumbent length, and after the age of 2 years, we have to take standing height. The values for length are at birth 50 centimeters, at 1 year 75, at 2 years 87.5, and after that it is 5 centimeters per year. This value of 5 centimeters must be remembered because if the child grows at less than 4.5, it might indicate growth failure on the part of the child. Now, all of you know about the growth charts. The important thing is that the percentile is not important. Whether the child is at 97th percentile, 75th percentile, or 10th percentile, if the child is growing parallel to his own percentile, we are happy. But if there is a stagnation in the percentile or if there is a loss of percentile, then that is a cause for concern. Now, every time a child comes to you, it is very important that while we plot the child's height percentile, we must also plot what is called the mean parental height. That is, what is the target height or what is the genetic potential for this child. Now, this is a very simple number which all of us should remember, that for boys, you take the mother's height plus father's height plus 13 centimeters and divide by 2. And this is the target height or the genetic potential for the child's growth. Plus minus 5.5 centimeters is the percentile variation which is acceptable. For girls, it is similar. You take mother's height plus father's height minus 13 centimeters divided by 2, and plus minus 5.5 is the deviation which is acceptable. So if the child goes beyond 5.5 centimeters of the target height, then this child may be a growth failure child and may need further investigations. A weight assessment is extremely important in pediatrics, and for weight for height, when you check under the age of 2 years, we go by weight for length percentile, which you can again see on the IIP app. And if the percentile is more than 95, this means that the child is overweight, and weight management should start in infancy when the child is crossing percentiles. Over the age of 2 years, in adults, you go through the BMI, as all of us know, but in children, we go through percentiles. The normal percentile is 5 to 85. Between 85 and 95 percentile, we call it overweight. 95 to 99, we call it class 1 obesity. And beyond 99, we call it class 2. If the weight for appropriate, if the percentage excess on the appropriate weight for height is more than 20%, that comes under class 2 obesity. And if it is more than 40%, this is called class 3 obesity. It is also called super obesity. So identifying obesity is very important. But one point to note, that if an obese child comes to you and you plot a graph and you tell the parents that your child is obese, then it means that you are actually labeling the child. And if you don't give them corrective advice, these parents often go overboard, and the results are disastrous because it can lead to eating disorders and yo-yoing of the weight, and the outcome is very poor. So these patients must be sent to a proper physician or a proper center which manages weight appropriately. The head circumference is always monitored. The growth is normally 2 centimeters per month, and then 1 centimeter per month, and then 0.5 centimeters per month. But sometimes you have a premature baby or a very large baby. Another simple formula is you take length divided by 2 plus 9.5. So measuring the head circumference is very important to identify microcephaly, macrocephaly, craniostenosis, and brain development. So this is very much a part of growth monitoring. Now, the second step in a well child care is we talk about infant nutrition, and I'll cover quickly 3 points. One is on milk, second is on solid foods, and the third is on nutritional supplements, which we often prescribe. Now, when we talk about milk, I think we all know that breast milk is the best, and the first 1 year, it's the best milk that you can give to the child. Feeding in the second year continues to give advantages for both the mother and the child. Formulas come as number 1 and number 2. That means first 6 months you use number 1 and second 6 months you use number 2. Now this number 2 is really more a marketing gimmick. It has only slightly more protein. And in practical terms, it does not make much difference whether you give number 1 or number 2. But most people will prescribe a number 2 formula after 6 months. After 12 months, it is not advantageous to continue formula, and it's perfectly sensible to move to fresh milk. Now, fresh milk under 6 months is controversial because of economic reasons, inappropriate dilution of formula. In India, we continue to advise fresh milk in the first 6 months, but nutritionally, it is not appropriate for infants. After 6 months, the WHO says it is reasonable to give fresh milk diluted and sweetened between 6 months and 12 months only for economic reasons. But the American Academy of Pediatrics has very strongly recommended that in infancy, all babies should be on only formula and not on fresh milk. So in a nutshell, after 1 year, switch to fresh milk. After 6 months, individualize, but try to push at least till 10, 11 months before you switch to fresh milk. When we talk about solid foods, the most important point is that in practice, you find a lot of people start solid foods very early. There is no advantage in starting foods before 6 months of age. Whether you start vegetables, cereal, fruit, or dals, it's a cultural difference, and different parts of the world and different states in India have their own way of doing it, but not to start solid foods before 6 months of age. Eggs are normally started after 9 months. Non-veg foods are started after 9 months. Very important, salt should not be given till 9 months of age because a young infant's kidneys are immature and it can lead to hypernatremia. Sugar should never be advised to a child. Jaggery may be a shade better than sugar, but it's also not advised to sweeten with the jaggery. If a parent wants to sweeten, you should use dry fruit to sweeten, which is much more nutritious. So better to avoid jaggery and sugar. Honey in any case is not advised till the baby turns 1 year. Spices are normally started after 9 to 12 months of age. Nutritional supplements, I'll spend some time here because it's a very common prescription. For a breastfed baby, all babies need vitamin D at birth, 400 units per day. Iron is normally started at 5 months of age in a dose of 1 milligram per kilogram. Normally you start with 5 milligrams, and once the baby is little bigger and older, you switch to about 10 milligrams of oral iron supplements. Formula-fed babies, we should remember that formula is completely fortified with vitamins and iron. But in the initial months, it is worth giving vitamin D even to a formula-fed baby. Once the intake of formula exceeds 20 or 22 ounces, then you no longer need to give any vitamin supplements or iron supplements for these babies because the formula is fortified. If a child is on fresh milk, we know that fresh milk is deficient in vitamin C and vitamin D. It may have reasonable amounts of vitamin A and B. So all these babies are given the multivitamin preparation and not only a vitamin D. And iron, like earlier, is normally started at 4 months of age. Should we be giving calcium to all babies? The answer is no. Calcium is not required for every baby unless indicated. A baby who is preterm, someone who has poor growth, someone who has excess growth, or someone whose milk intake is reduced, then calcium is added. It is not given to every child. You have a variety of supplements where they have amino acids and proteins in infancy. It adds to the cost, achieves little, and it is not recommended. A DHA is a hot topic for brain development. Should we be giving DHA to all infants? To premature babies, it has been shown to be beneficial, but for older children on a normal diet, it is not recommended to routinely give DHA. It is sometimes given to those with any neurological problem, but normal babies don't. But it's good practice to advise all parents to give some walnuts and dry fruit, which has natural DHA in their diet. Of course, the non-veg will get it from their fish and non-vegetarian foods. What about older children? Should we be giving any nutritional supplements to older children? The temptation to start nutritional supplements like Pediasure, etc., is to be strictly avoided. They do work because they are calorie rich, but they work largely because of the sugar content. And most of us don't like Pediasure or equivalents because of the high sugar content of these products. Should we be giving multivitamins to all babies? It's probably not harmful, but it's probably not necessary. If you have a picky eater, if you have someone with inadequate growth, then it makes good sense to give a multivitamin. But for a well-nourished child who's active and growing well, it probably doesn't make any difference if you give multivitamins or you don't. Should we be giving iron to all babies, all children? The ICMR has given a guideline that if you give 1 month of oral iron at 3 milligram per kilogram in a year, This goes a long way in preventing iron deficiency anemia. A lot of pediatricians do that. I've been doing it for a very long time. So when they come for a sick child visit, I just give them some iron for 1 month as a top up for iron deficiency. A vitamin D, there is no guideline, but as we know that vitamin D deficiency is quite rampant. And therefore, I periodically, whenever they come for an annual check or for a sick child visit, I give a couple of doses of vitamin D orally, 60,000 units, a couple of doses, and I think that will probably maintain the vitamin D, but there is no clear recommendation on this. Now we next come to behavior, and I think it's very important that parents are guided about sleep patterns because it's a cause for great concern to a large number of parents about how their child is sleeping. Now, for the first 6 weeks, there is no day and there is no night, and babies get up every 3 hours and they get up at least twice at night for a feed, and this is considered normal. But between 6 and 12 months, a baby can be and should be coaxed into a longer gap, and it's possible for the mother to achieve a gap of 6 hours, that is 12 to 6 or 11 to 5. So the mother gets rest and the baby's diurnal rhythm is also established. Between 3 and 6 months, it's possible to stretch to 6 to 8 hours, and babies do sleep well. After 6 months, they can sleep as long as 10 hours with one dream feed, either at 11 o'clock or in the middle of the night, and just for a quick feed and they go to sleep. And it's possible to achieve a gap of almost 10 hours for these babies. Now, around 5 months, the sleep cycles get established in the baby, that babies don't fall asleep, remain asleep and wake up. They go into the light sleep and deep sleep, and these cycles alternate every 90 to 120 minutes. That means every 1.5 to 2 hours, the child will be in light sleep. By now, the child is smarter. They develop what is called separation anxiety and they cry. Now, kind mothers will pick up the child, they'll rock, they'll sing, they feed, and they put back to sleep. And this very quickly goes into a comforting sleep ritual. And then the babies get habituated to waking up at night. And a nice, kind mother does it happily at 6 months. But if it goes on for a year, then they start pulling their hair and they are really disturbed and distressed by the continuous awakening at night. So how do we help the baby to sleep through the night? Almost a third of babies have sleep disturbances, and it's the duty of our doctors when the patients come to us to encourage good sleep patterns for babies. So simple behavior management and advice usually works. Sometimes if it doesn't work, drastic measures were recommended in the West. It's called Faber technique, when they allow the child to cry at night and put themselves to sleep. This is generally culturally not accepted in India. There are many variations in sleep training. A very popular one is called pick up and put down method. But I think there's not enough time to discuss sleep training at this point. But suffice to say that it's very important that we tell parents and teach parents to encourage good sleeping habits in their infants. Now, this is a very important slide. And what this tells us is that this whole world is sleep deprived, unfortunately, including children. And if you look at this slide, between the ages of 6 and 13, they're supposed to be sleeping 10 hours. Between 14 and 17, they're supposed to be sleeping 9 hours. And even younger infants, if you see the amount of sleep they require, it is much more than what they're getting. Indian families, they tend to work late, come home late, dinners are late, and babies sleep very late. And we know that sleep impacts not only a child's growth, but also the mental functioning and the attention span in the daytime. And children do much better with better sleep habits. And this is something which really needs attention when they come to you for routine visits. Child safety is something which we must pay attention to. And worldwide, there are 2,000 deaths a day, and it's a leading cause of death above the age of 1 year. And all that can go wrong, I've mentioned here, we are all aware of it, but it's important for us to counsel, and parents should know that paying attention to a child's safety is extremely important. Now we come to the second half, and I'll be talking about screening tests for children. The guidelines have been laid by the American Academy of Pediatrics and the United States Preventive Services Task Force. Now there are grades of utility and evidence of grade. So not all recommendations are strongly beneficial, but we have to have some guideline on how to follow. Most of what I talk will be following these two sites. In the newborn period, we do 3 things. We check for hearing loss, we check for metabolic screening, and we check for critical congenital heart disease. Now, universal hearing screening, most hospitals are doing now, And you'll be surprised to know that in an apparent healthy child with no risk factor, the incidence may be 1 or sometimes 2 per 1,000. That means about 1 in 800 babies may have a hearing impairment. And it's not that you can hear or you can't hear. It may be 1 year, it may be 30% less, and it's very easy to miss. So it's extremely important that we check all babies for hearing. For high risk babies, the incidence may be 2 to 4%. And by high risk, we mean premature babies, birth asphyxia, NICU stay, aminoglycosides, craniofacial malformations, family history, etc. So for low risk babies, normally we do OAE, or what is called autoacoustic emission. The result comes as either pass or refer. Refer means it's doubtful, you have to repeat. So either we repeat the OAE or we go in straight for a BERA, which is a definitive test. For high risk infants, we go in for a BERA straight away. So this is extremely important and very cost effective. Metabolic screening is also done in most of the maternity units now. The basic screening covers the common conditions which we see, and this includes congenital hypothyroidism, congenital adrenal hyperplasia, phenylketonuria, galactosemia, biotinidase, and we often screen for hemoglobinopathies and cystic fibrosis. There is something called extended screening, which covers for rarer conditions. It adds to the cost by about 3,500 rupees, where you also check for amino acidopathies, urea cycle disorders, and organic acidemias and immune deficiencies. Overall, if you see, the only condition which is really cost effective is congenital hypothyroidism, very common condition, 1 in 3,000 cases. And after we launched the screening program at Beach Candy many years ago, we've been picking up cases regularly, and it's a very, very cost effective screening test. The next is we screen for critical congenital heart disease. The incidence is almost 1%, that is 8 per 1,000. The way it is done that after the age of 24 hours, we do a pulse oximetry on the right upper limb and either lower limbs, and a normal reading is a saturation of more than 95%, and the difference between the upper limb and the lower limb should be less than 3%. That means if your reading is less than 95% or the difference is more than 3%, it is considered abnormal. This is about 75% sensitive, but 99% specific. And if there's any doubt and you have to do an echo, it's very important to identify these conditions early, because the outcome improves with early diagnosis. A hip dysplasia is something which we don't pay much attention to. The 1 to 2 per 1,000 is Western data. There is no Indian data. My personal feeling is that it is much less common in India, because we've been checking hips of all babies for many years. We do find the hip dysplasia, but it's not as common as what these numbers suggest. However, we are supposed to check all babies for hip dysplasia at birth, at the 2-week visit, and every visit till the child walks. The screening test for hip dysplasia is sonography. In Europe, particularly in Germany, they started routine screening for all babies with a hip sonography many years ago, because it seems to be very common in Germany. We do it if there are clinical signs, and at 6 weeks in high risk cases, that means all the breech deliveries, or if there is a family history, then they are all screened at 6 weeks. They are not screened at birth, because you have a large number of false positive results if you do it at birth, but the results are much more reliable when you do it at 6 weeks. So this is something which is very important. Vision screening, extremely important, because 5 to 10% of children have undetected vision problems. And if you don't identify early, then they can land up with amblyopia and blindness. And this is a tragedy. If you don't diagnose a vision problem and don't rectify it, you can lose eyesight. And this is very important. So all babies at birth, the eyes are checked. In low risk population, you're supposed to send to an ophthalmologist for an eye check at 3 years. And I can't tell you how important it is, because many a child has refractive errors, which you cannot otherwise make out. And if you don't identify it early, the eye can get lazy and then get amblyopic. So it's very important. Beyond the 5 years, there is a schedule for testing children periodically. Less cost effective, nevertheless recommended. Anemia screening, very important. In USA, you'll be having relations, I'm sure, and all babies are tested for iron deficiency and low hemoglobin between 9 and 12 months. In USA, the prevalence is 5%, despite all of them being on iron supplements. In India, under the age of 5 years, the incidence of iron deficiency is 70%. So there is no clear guideline that all our children should be screened for iron deficiency. But at the first opportunity, we must do a hemoglobin and a CBC for all children in the first few years of life. Even if you don't do it, be sure that you give iron supplements. It's extremely important to give iron supplements to babies in infancy because the iron deficiency, as we've seen, is really, really high. When you screen for anemia till the age of 5 years, hemoglobin less than 11 and ferritin less than 12, we don't check ferritin, we go more by the hemoglobin, indicates possible iron deficiency and need for iron supplements. Between 5 and 12 years, the cutoff is 11.5. So if your hemoglobin is less than 11.5, then these children need iron supplements and perhaps investigations. Dental screening, equally important. The American Academy of Pediatrics says that all children should be screened for dental health between 12 months and 18 months. And preventive dentistry is extremely important because there is a 22% reduction in dental procedures. And all of us have seen and quite horrified to find that 3 and 4-year-old children have root canals and caps fitted and general anesthesia and large bills for poor dental health and poor supervision. All this can be prevented if you send to a good dentist in infancy and all the preventive measures are taken. Just a note about fluoride, that after the age of 4 or 5, they need adult fluoride toothpaste. Beyond 2 years, they need junior fluoride toothpaste. Under 2 years, the CDC says fluoride free, but the American Academy of Pediatrics says that you must use junior fluoride toothpaste. But because small children can't gargle, you must just take like half a grain of rice, just a tiny amount of paste so that they don't swallow, but dental health is improved. This is very important. Developmental screening is very much a part of pediatrics, and it's extremely tragic that in our busy practice, all of us continue to miss developmental problems and we diagnose problems late. And we have to identify motor delays, which are quite easy. Means if a child doesn't walk, then it's very obvious and you send for therapy or you start some investigations. But speech and language is often neglected. And when there is a delay in speech, we often reassure that the grandfather spoke late and the uncle spoke late and don't worry about it. But they need attention because many of them have problems. Now, autism is a big topic, as you know, and the incidence now in US, where they screen very vigilantly, is 1 in 66. I mean, that's much more than 1% now. So there are lots of developmental screening tools and charts which are available. Most pediatricians know what the normal milestones are, but we have a time deficit. And most of us who miss it is because we don't ask questions in our busy practice. So it's very important that periodically, they say at 9 months, 18 months, and 30 months, you must ask appropriate questions and make sure it's okay. Autism, very important to diagnose early. Ideally, it should be diagnosed at 18 months. In USA, you'll be shocked to know that the average age of diagnosis is 3 to 3.5 years. And I'm sure in India, we are doing even worse. So I think developmental delays are missed very commonly, and we have to pay attention. When an adolescent comes to you, I think it's very important that we have a relationship with our older children and ask about depression, tobacco, substance abuse, relationship problems, sexual health, because unless you ask and unless they feel comfortable talking, they're not going to talk about all the issues in their life. And we just have to read the papers to see that adolescents are in bad shape in our world. Hypertension, very important. Even if there are no risk factors, after the age of 3 years, we are supposed to check the blood pressure annually. If there are risk factors, we have to check at every visit. And risk factors means low birth weight babies and those with underlying systemic illness, renal disease, or those with obesity and diabetes. So this is one more area where pediatricians and family physicians tend to neglect. Diabetes, we know that adult onset diabetes is coming more and more because of obesity. And all overweight and obese children must be screened for diabetes. And if there are risk factors, even if the child is not obese, you have to be very vigilant and test for diabetes. And the risk factors include family history of diabetes, maternal diabetes in pregnancy, and if there are any signs of insulin resistance in the child, which means that if you have acanthosis, meaning pigmentation on the neck, if you have hypertension, if there is dyslipidemia, or small for gestational age babies, or if you have PCOD in an adolescent girl, then it's very important that we test for diabetes. Now, dyslipidemias, I know that all adults go for their health checkups and are paranoid about their LDL and cholesterol. But by the time you diagnose in adults, the damage is already done. And it's very important that dyslipidemias are detected in childhood so that if you take appropriate steps, then you can prevent coronary artery disease from developing. So, under 2 years, screening is not advised. Between 2 and 8 years, only high risk children are screened. That means those who are obese or have hypertension, systemic illness, or if you have a family history of coronary artery disease or hyperlipidemia, then you have to start checking between 2 and 8 years. This is something which is again neglected because we often don't ask for family history and don't do this. The AAPS says that between 9 and 11 years once, and once between 17 and 21 years, all children and young adults must be screened for dyslipidemias to prevent long-term coronary artery disease. So the take-home message is that a well-child visit is not a vaccination visit. We have to do much more. As pediatricians and family physicians, we have a relationship with our families. It's very important that we take this opportunity and take steps for prevention and promotion of good health. And there are clear guidelines given by American Academy and the Indian Academy of Pediatrics. And I think if we follow this, I think the general health of our children will be much better and will be much healthier as adults. Thank you.
Thank you, Dr.
That was a wonderful talk, Dr. Balsekar. There's a question from Dr. Vijay Khambati. What about salt and sugar intake till the age of 1 year? And what about cow milk?
So I think I had talked about this in this talk. Salt is advised only after 9 months of age, and even after that it should be restricted. Sugar is the biggest enemy in our life, as we all know. We should not advise. For all the Gujaratis in this group, jaggery may be a shade better than sugar, but even that should be avoided. Honey, like I said, should not be given till the child is 1 year old at least. And the second question was fresh milk. It should be used after 1 year of age. Before that, it is used only for economic reasons or because of the risk of inappropriate dilution of formula and diarrhea and problems like that. Every nutritional body says fresh milk only after 1 year. In practice, you may start at 10, 11 months, but not before that.
Sir, I'm Dr.
Another question.
Can I make a comment, sir? 1 or 2 minutes, can I make a comment?
Sure.
Sir, it is...
Yeah, sure.
Sir, I am Dr. Shrikant Rao. Can I make a comment, sir?
Yes,
Yeah,
Sir,
please.
it is a wonderful talk, sir. The wide gamut of the nutrition, the various disorders to pick up things, screening, and whole topic of pediatrics you have covered in such a short period. That was great to listen to you. I would like to make 1 or 2 small comments. You said the iron deficiency anemia in US is about 5%. In India, it is about 70%. That is quite alarming. That shows we are basically lagging behind in our annual checkup and our screening and in our well-baby clinics. Our approach has to change because every doctor, now what we are doing is we are practicing something like a need base. Somebody is down with diarrhea, give anti-diarrhea medicine. Somebody with the flu, give flu medicine. And then the whole story gets neglected and they don't come for follow-up also. I think a particular day every week or at least once in 2 weeks, we have to have something like a vaccine come well baby clinic for all the doctors, for all family physicians, so that the culture of doing the annual checkup, periodic checkup, the screening and the entire thing gets streamlined. Otherwise, it becomes a totally neglected area. Most of the doctors have no fridge in their clinic. Most of the doctors have no baby weighing machines, no adult weighing machines, no measuring tapes. These are such small, simple, basic things. And if it is, if the facilities are made available and if the culture is given and educated to the parents, I think that goes a long way in giving better results and better practice to the doctor, better professional satisfaction, better results to the children, and we'll get a better future population. I think this is the comment I would like to make. And another thing is this childhood obesity is becoming a very big problem in a major city like Bangalore. On one side, we have the undernutrition, kwashiorkor marasmus, on the other side, the obesity, and they are going to be future diabetics and the cardiac patients. I think what you impressed is really great because the follow-up and prevention gives wonderful results in the long run, sir. Your message is well taken. I would like to thank you, sir.
Thank
Cyrus,
you.
please go ahead.
There's one more. Yeah, there's one more question. Dr. Saurabh is asking, he wanted to know what is the suggestion, which milk is to be used for a child which is not breastfeeding. And these days we have many commercial so-called organic milks available using A2 milk like Vita Farms, Provilac, etc. So do you recommend this?
So I've tried to read about this A2 milk because that's the flavor of the month right now. Every mother asks about A2 milk. Unfortunately, there is not enough literature to say that it is superior. It has some theoretical advantage, but there is no guideline to say that A2 milk should be used. About organic, all of us like the word organic and we would all love to have pure milk. But whether it is genuinely organic or is just added cost and labeling, I have no idea. So I am not sure.
And Dr. Balsekar is absolutely right that the vision screening is very, very important. We see children at the age of 5, 6 who just walk in for just a routine check. And we found a lot of amblyopia easily treated early on. We find children that are 10 years old that come for the first vision check at 10 with an isometropic amblyopia, which is very easily treated early on, and then we can't do very much. We find people coming at 13 and 14 for a first vision check, where the amblyopia has already become deep, and there's nothing much we can do then. So sir is absolutely right that at the age of 3 or 4, children must come in to an ophthalmologist wherever they are in whichever part of the country for a vision assessment.
Sir, one last question. Roll-up massage in child care. Roll-up massage.
So
Dr. Balsekar.
So massage is a tradition, and pediatricians often discourage massage. It's something I don't agree with. So I think it's perfectly okay that if adults go for massage, why not a baby? So I think babies enjoy the massage, and there are theoretical advantages also, right from better weight gain to they sleep better and they're soothed by it. But obviously there are some precautions that we have to take. That some babies are allergic to the oils, and especially if you use organic, this chana, besan, masoor, all that, then you often get dermatitis, infection. So it is normally discouraged by pediatricians for that reason. So if you get any allergy, you have to stop. And of course, as we know, they put oil in the ears and nose, and that can cause some side effects. So massage is something which I actually encourage. It's good, as long as you take a few precautions.
One last question to Dr. Rahul Verma. Dr. Rahul, can you unmute?
Very much.
Yeah. Is there any way prenatally to suspect or diagnose or some deficiencies in the mother which leads to more of abnormal movements in the child? Is there any preventive mechanism? Is there any way to diagnose prenatally?
So I'm not aware of any prenatal diagnosis for abnormal movements. However, paucity of movements, that means a fetus who does not move a lot in utero, definitely should be a high suspect for musculoskeletal disorders, hypotonic syndrome, but not for abnormal movement disorders.
Oh, thank you.
Yeah.
Sir, so Dr. Mahesh Bhai.
Please come closer to the speaker. Your microphone is not working. On a personal note, Dr. Balsekar, it's exactly 27 years since we met when my twins were born, and they both send you the regards today. So they were asking me, I said, he looks the same. I don't.
So, when babies you've seen at birth come back to you as parents, I call them my VIP list. And it's a great pleasure to see babies grow and become parents and come back to you.
We can proceed, Dr. Jawar.
We still can't hear you.
Dr. Jawar, we can proceed.
Yes,
I think so.
We should proceed now.
I shall now call upon Dr. Vibhakar Advaryu to introduce Dr. Rasik Shah and call upon Dr. Bharat Bhatt, Dr. Jahan Cooper, and Dr. Suryakant Pandit from the GPA, our colleagues and friends from the GPA, to come set the stage, please. To introduce Dr. Rasik Shah.
please. Dr. Vibhakar, unmute, please. Dr. Vibhakar, unmute. Unmute yourself.
Yeah. I've done it. Good morning, everybody. Dr. Rasik Shah is a senior full-time pediatric surgeon at SRCC NH Children's Hospital with 35 years of surgical experience. He has been trained at Sir JJ Group of Hospitals and University of Tennessee, USA. He is a pioneer of laparoscopic surgery, urology, and cancer surgery in children. He is skillful in carrying out all types of basic and advanced laparoscopic and thoracoscopic surgery. To his credit, there are many articles, guest lectures, and operative demonstrations. He has uploaded 112 videos on YouTube and conducted many webinars. He has trained more than 350 pediatric surgeons at Center of Excellence in Minimal Access Surgical Training. He is past president and secretary of Indian Association of Pediatric Surgeons and Pediatric Endoscopic Surgeons of India, of Indian Association of Pediatric Surgeons. Friends, I present Dr. Rasik Shah to you. Dr. Rasik Shah, please.
Thank you. Thank you, Dr. Vibhakar, for such a nice and wonderful introduction. And I will start my talk on bedside spot diagnosis. Okay, can you see my screen? Hello?
Yes, we can.
Okay. Yes. So before I start my talk, I will give a disclaimer. We wanted to have one rapid fire round of diagnosis, but unfortunately we are live streaming on YouTube. And when we do that, we can't have any photographs of external genitalia because YouTube artificial intelligence will immediately stop the presentation and live streaming. So I had to modify my talk, and we will go through some of the common diseases. We'll discuss about the important aspects which are important for general practitioners to know, and we will proceed. So, okay, so here is a newborn who was born with a cyst or swelling under the tongue, which was bluish. And obviously, we know the diagnosis is ranula. Ranula means, it's a Latin word, it means frog. It is a fluctuant, bluish, translucent swelling, and it resembles frog. It is like mucus retention cysts. There is no role of aspiration. Surgery is marsupialization, like what you see, we have excised the part of the cyst and then you underrun the edges. And if you try to excise completely, you may damage some of the mucous duct and there can be a problem. The plunging ranula means it goes into the neck. It is such a large one. The surgery will remain the same. So this is the second patient where you can see a large swelling at the base of the tongue. Now, there is a differential diagnosis when you have something like this, which includes the lingual thyroid and maybe dermoid and lymphatic cyst and all that. So this particular patient had a lingual thyroid. So what is lingual thyroid? It is a developmental aberration of thyroid failure to descent. As all of you know, it develops here and then goes into the neck. And most of the time when you have ectopic thyroid, like lingual thyroid, that's the only tissue which is present. So once you excise that, there is no more thyroid tissue left and the child will need the replacement. The symptoms are due to size. There will be sudden increase in the size when more thyroid hormones are required. So at puberty, it will increase in the size. At menarche, it will increase in the size. And any stressful condition, it will increase in the size. The symptoms will include bleeding, dysphagia, and respiratory distress. And of course, along with that, hypothyroidism. So investigation, as I told you, we need to do T3, T4, TSH and thyroid scan, sonography of the neck. So this is basically to see whether there is any normal thyroid tissue is present at normal site or not, and whether the child is normal euthyroid or hypothyroid. So accordingly, you need to manage. The surgery is excision of this particular swelling. So here we did excision transorally, but we can go through the neck also divide the mylohyoid muscle and take out the swelling. So we have done both approach in some of the patients. One can try and make it in small pieces and implant in the rectus abdominis. But this patient needs a lifetime hormonal replacement. The third is the patient presenting with the sinus at the junction of upper two-third with lower one-third of sternomastoid on the anterior edge of the sternomastoid. And when you have this, the diagnosis is bronchial sinus. So that is bronchial sinus. Again, it is a developmental anomaly. It is because of failure of bronchial cleft to obliterate completely. The external opening, as I told you, location. The internal opening is always a tonsillar pillar. Sometimes if it is open, then it is known as bronchial fistula. If it is not open, then it is a bronchial sinus. When there is a fistula, when the child drinks milk or water, sometimes it comes out through that opening. So the symptoms are discharging sinus, usually mucus, and occasionally ingested liquid if it is fistula. Diagnosis is clinical. Once you know it. You don't need to investigate in any form. Sinogram is not required because it can cause infection, and the treatment is surgical excision. This was in an older child, so we had to take a step ladder incision to take it out, and this tract was about 5.5 to 6 centimeter in length. So this is bronchial sinus. We'll go to the next one. So here again something similar. So this is a swelling there at the junction of upper two-third with lower one-third. This was in a 1-year-old child, and we excise that. So you can see there is a cyst, there is a tract. So this is a bronchial cyst with the sinus. So bronchial cyst with the sinus. If we don't excise, they can develop infection, pain, fever, and abscess, and then you may need to drain it and then go in again and take out the swelling completely. If you leave behind this, then sometimes there can be recurrence. So that is bronchial cyst with sinus. Then another common thing is swelling in the midline at the level of hyoid or between the hyoid and thyroid gland or cricoid. So that is classically known as thyroglossal cyst. Occasionally after infection, they develop a fistula. So this is a cyst, and this particular child had infection and developed the fistula. The treatment or the diagnosis is swelling at the level of hyoid generally, but it can be up and down. It can sometimes present even within the tongue also as a swelling. It moves with deglutition and protrusion of tongue. Rarely it can get infected. Investigations will again, like lingual thyroid, you need to find out whether there is a normal thyroid tissue or not. Now, clinically, if you want to find out, what you are supposed to do is feel for the tracheal ring. Normally, you can't feel the tracheal ring, which are second, third, fourth, because of the isthmus of thyroid gland is lying over there. So if you can feel the tracheal ring continuously, it means the normal thyroid tissue is not present. But even after suspicion, you have to do sonography to confirm whether the thyroid gland is present or not. The surgery will remain as a cyst trunk surgery. What is cyst trunk surgery? You, along with this particular cyst, you take out the central 1 centimeter of hyoid bone. If you leave behind, then some part of the tract will be left behind, and this can cause the recurrence. So thyroglossal cyst treatment is surgical, cyst trunk operation, taking out the central part of the hyoid bone. And surgery usually, usually they don't present in first few months of life. Once the mucus starts getting accumulated, they will present around 1 year. So whenever they present, we like to take it out. Then another common thing what you will see as a general practitioner is a sinus which is just located at the anterior part of the ear. So usually discharges little bit of mucus, but if sometimes it gets infected like this and forms an abscess, and in both basically it will need to be excised. So when there is an abscess, you just drain it and then go in and excise it later on. 10% of this will be bilateral and familial. The treatment again remains is the complete excision. If you leave behind something, again, it can recur. And we have seen the child which has recurred second time, third time, fourth time, and then they reach to the appropriate place and then they get all right. Now, this is another thing which you will see in the infancy is a sternomastoid contracture. So you can see that's the sternomastoid muscle which is quite contracted, and the problem with that is hemifacial hypoplasia. The side which is contracted, the child is pulling down, that side gets hypoplastic, and if you see the skull, they will develop plagiocephaly. So this will become flat. Now, if anything of this complication is developed, then of course they will need intervention. So etiology, we don't know, but it can be because of the birth trauma or in utero malposition of the head and face. And due to contracture, there is lateral bending and rotation. Typically, it is bent and rotated towards the affected side. There is a differential diagnosis of this. Lot of things are possible, but these are three common things: that cervical hemivertebrae. Sometimes it is because of the ophthalmic condition, because of the squint, they will keep the head like that. And then there are acquired infective and inflammatory conditions in the neck. If there is if you don't see obvious contracture, but if the child is keeping head like this, you have to get the X-ray of cervical spine, epi and lateral to rule out the cervical hemivertebra. The treatment is initially you do physiotherapy, and most of the time with physiotherapy, you can cure this disease. The position of head in a newborn period with the help of pillows. So whichever side you want, the child is suppose looking continuously on the left side, you keep the pillows over here so the child looks on the right side. You keep the door open on the other side so that when you call the child has to move against the contracture side. So all this maneuver you do, and you do physiotherapy along with that. And most of the time with this, it will be all right. But occasionally, if child does not get all right with that, then they need a surgery. In surgery, unfortunately, this picture is not good quality over here. But what you do is divide the muscles, sternomastoid muscles, till you see the internal jugular vein. Today, we do that endoscopically, meaning we put our camera port and instrument port from the axillary fold, go right up to there, create the space and divide the muscle using diathermy hook. So there is no scar in the neck. So this is known as still surgery, and for sternomastoid contracture, it can be done easily if required. The next, again, very common thing is a mucous cyst, and mucous cyst usually you find in the lower lip. It is a bluish translucent cystic swelling, usually in lower lip because of the dental trauma. So whenever you have this cyst, you have to look for any dental problem. If it is there, you need to take care of that. If you don't take care of that, just excise the cyst, then it can recur. So you want to find out if there is any dental trauma chronic, you want to go in, take care of that. So you can try initially conservative management, but if the child is not improving that, it is refilling 2, 3, 4 times after it bursts, it comes out mucus, it refills, then you need to go in and excise that completely. Then another common thing which you will see in a newborn is a hemangioma, not newborn, but infant. What is the natural history? It increases in size for first 9 to 12 months, then remains static for 1 to 3 years. And at the age of 3 years, it starts involuting and disappears in 50% by 5 years, 75% by 7 years, and in 95% by 9 years. The treatment is observation most of the time, but if it is rapidly increasing in size, one should treat it. Or if there are symptoms like ulceration, bleeding, impaired normal function, if it is in eye and if it is getting, the eye is not able to open, if there is a combing, means if it is in scalp and combing becomes difficult, if it is in trachea with respiratory obstruction, low platelet count, cardiac failure because of the sort of large turnover of blood in when they are very large hemangioma. So in all these conditions, you need to treat them. So today we treat it with oral propranolol, and which has a beautiful good results. We start with low dose, but we can go up to 3 to 4 milligram per kilogram per day, and response rate is very good. More than 90% of this kid improves. Then if that does not work, then we can use oral steroid in the dose of 2 to 4 milligram per kilogram. Either you can give alternate day or daily. If you give alternate day, then the suppression of the axis is less. Excellent response in 30%, mild in 40, and then 30%. If that does not work, we give intralesional steroids, and with that the response rate is about 75%. In some patient, if nothing works, then you may need to try interferon, and the laser ablation occasionally for superficial lesion can be done. The important thing is once it starts involuting, the size goes down, there are grayish discoloration which you will see. So that means it is started involuting. Then another condition which you will see is a lymphangioma. Again, it's a developmental anomaly. There is a sequestration of lymphatics. The exact cause we don't know. Many of these lymphangioma or cystic hygroma, they are not just pure lymphatic malformation. Along with that, they have a component of hemangioma. So when there is a hemangioma, lymphangioma, and all the other tissues which are joined together, what we call is a hamartoma. And hamartoma will not get all right. Hemangioma gets all right. Hamartoma, lymphangioma, they don't get all right. They need some treatment. And if it is amenable to surgery, that is the best thing, you take it out. Sometimes it is not amenable to surgery, then we may need to do something else. So there are other common sites which includes axilla, mediastinum, and bowel mesentery. Antenatal detection, if it is detected antenatally, then you need to rule out the genetic disorders, and many of them will disappear with time. In girls, you have to be, if they have cystic hygroma in neck, antenatally detected, postnatally they can have Turner syndrome. So you have to look for it, and accordingly you need to manage. Complication includes bleeding, infection, respiratory distress, and dysphagia. And if it is there, we need to take care of that. The treatment, as I told you, is excision in many patients, but sometimes if it is located on the eyeball, I can't take it out. Then I will like to use sclerosant to decrease the size. And we have multiple of sclerosants available, which includes bleomycin, very good results. Sodium tetrahydroxy sulfate, doxycycline, and many other things can be used. Complete resolution with sclerosant, particularly if it is macrocystic. Sometimes it is mixed, micro and macrocystic, then the response is poor. And if it is microcystic, then the results of bleomycin or sclerosants are not very good. Occasionally, one needs to treat with radiation therapy or laser, which we have never used, and they don't work well. Then another common thing which you will see is the umbilical swelling, which is because of the umbilical hernia. So usually it is reducible swelling, more common in African girls than what we see in Asian population or Indian population. Usually it resolves by 2-3 years old. So as the child starts sitting, walking, the rectus fascia will come together and it will close off this particular ring. So when the complication will include irreducibility, obstruction, and strangulation, though not common, it can happen. The indication of surgery is persistence beyond the age of 3 years, or if there is a complication, which I already mentioned, or if on follow-up, if you see the ring is widening, primarily if I see the ring is widening more than 2 centimeters, or if on follow-up from 1 to 2 centimeters, then I need to repair. I may not wait for the 3 years age. And in some of the patients, you need to rule out hypothyroidism. Another thing which you will see in a first few months of life is umbilical granuloma. Now, usually it is the remnant of umbilical cord. The differential diagnosis includes other causes of umbilical discharge, we will see, but in next slides. But the treatment for umbilical granuloma is you need to cauterize it using either chemical stuff like spirit, silver nitrate, copper sulfate. Occasionally we can cauterize that. Or you can tie a suture at the base of the granuloma, and once for all, you can get rid of that. Now, what are the other causes of discharge? We discussed about granuloma. Second is the remnant of vitellointestinal duct. Then the remnant of urachus. So these are the causes, and you can see over here, that is a patent vitellointestinal duct. And these are all different types of the patent vitellointestinal duct. This is raspberry tumor, that is enterocystoma, that's a fibrous cord or band, that is Makers with the cord, and that's just a Makers. And this is a patent urachus. So patent urachus, here the part of the urachus is open on the umbilical side. Here there is a cyst, and here it is part from the bladder which is open. So in all this condition, you need to go in and excise it. We try and do sinogram in this patient, so we know what we are dealing with, but umbilical discharge beyond 2-3 months of life will need 99% of this patient will need surgery. Then phimosis, again, it's very common and all of you know about it, but we call it as a physiological in first few years of life. It becomes pathological when there is a ballooning of prepuce. There is recurrent attacks of balanoposthitis. If you can't see the external urethral meatus, or if there is a paraphimosis, history of paraphimosis. The contraindication of surgery will include if there is a patient has hypospadias or epispadias, or if there is a bleeding disorders. The management is observation. If it is physiological, we don't advise any forceful retraction. With forceful retraction, there can be cracks, and all cracks will heal with fibrosis. So somebody who does not have pathological phimosis, it can become pathological. Local steroid ointment like betamethasone can help, but we don't advise use more than 3 weeks. An indication will be recurrent infection, or if they have ballooning, or you can't retract completely beyond a particular age like 3 years. The patient has associated urinary anomalies, then they should undergo circumcision, and some of the patient will undergo circumcision for religious reason. Now, mild descended testes. Mild descended testes is testes which is not in the scrotum. If I have to classify that, then it is undescended, ectopic, retractile, and ascended testicle. Undescended testicle means it is in the path of the descent from the lower pole of the kidney to the scrotum. Ectopic means it is diverted from the normal path. Third is retractile, means it has gone to the scrotum, but it comes up. And fourth is ascended, means it has gone down, but at later date it comes up. So this is all different types. But as far as the surgeon or clinician is concerned, there are 2 types: palpable mild descended testes or non-palpable. Palpable needs open surgery, non-palpable needs a laparoscopy surgery. Ideal age to operate will be at the age of 6 months, and earlier than 6 months when they have associated hernia. The retractile testis, if behaves like undescended testis, then it should be operated. Ascended testis should be operated whenever they present. Why you need to operate? Because if you don't operate, if it remains up, it will cause decrease in the function because of the higher temperature, higher incidence of malignancy if not operated. Usually there is a 70% chance of associated patent processes vaginalis, and you need to take care of that. Higher incidence of torsion, increased incidence of injury, psychological issue, and cancer. So after surgery also, you need to teach them self-examination so they can detect the cancer early. Now in unilateral undescended testes, preoperatively, you just need to do CBC. We don't advise any sonography because that is fallacious and it does not give us exact idea. Whatever the results, you still need to operate undescended testes. If it is not palpable, we do it laparoscopically. And if it is bilateral, then you need to investigate for disorders of sexual disease or DSD. They can have anything like intersex disorders. We will not go into details of that. So this is the laparoscopy finding of the undescended testes, which is near the ring. Then vas and vessels entering the internal ring, very high testes almost near the kidney, and blind ending vas and vessels. We will not go into details of that. I can't show you any photographs because YouTube will block that. Inguinoscrotal swelling or hernia or hydrocele. Again, the complications will include incarceration, obstruction, strangulation. surgery as early as possible because it can undergo complications. The chances of complication in a first 6 months of the life is almost 50 to 60%. So once the hernia is diagnosed, you don't want to wait because that is calling for the problem. Then in prematures, ideally we advise surgery before the discharge from the hospital. If we don't operate, then again, the chances of coming with the complications are very high. This is one of the patient, girl child, who presented with hernia, and before we could operate, had torsion of the ovary and we lost the ovary. So in females, when you have palpable ovary, it is better to perform the surgery as early as possible. Even in hydrocele, we will do surgery as early as possible. I mean, in hydrocele, we do around 1 year. We give time in case if there was a patent processes as blocked off, then the fluid in the hydrocele sac will get absorbed and then they may not need surgery. Now surgery, we can do it laparoscopically or we can do it open. The advantage of laparoscopy is you can see the opposite foramina. If there's a patent processes on the opposite side, you can tackle that at the same time. As I told you, in the child who is less than 6 months old, the chances of patent processes is almost 50 to 60%. At the age of 2 years, that incidence goes down to about 20%. And at the age of 8 years, it goes down to 8%. But most of the time, if you do it, you can prevent one more surgery to this patient. The other advantage is the incision what we take about 3 to 4 centimeter for open repair. You go through skin, subcute, fascia, cremaster to reach to the hernial sac. When we do it laparoscopy, we are directly working on the internal ring, and that is the advantage. You don't disrupt any lymphatics, venous stuff. The other advantage is everything is under magnification. The chances of injury to vas and vessels are very, very low. As compared to open surgery, where the incidence is about 1.5 to 2% in a large series published from USA. So these are the advantages. Of course, in a bilateral hernia, it reduces operating time significantly. In case of recurrent hernia, you are going from virgin field. So it is easier to perform it laparoscopically than doing it open. So these are all advantages. Disadvantage is you need to give controlled general anesthesia, requires special equipment and experienced personnel. Though there is reported higher incidence of recurrence in some of the series, but we do exactly what we do in open surgery, and our recurrence rate is almost zero. I can say we had one recurrence out of 800, 900 cases. Then torsion test is, again, I can't show you the photographs, but it is more common in teenager as well as in infants, but it can occur in entire childhood area. The problem is acute onset of pain, swelling, redness in the scrotum. The differential diagnosis will include torsion of testes with epididymoorchitis. The investigations include color Doppler and urine examination. Why we do urine examination? Because if there is epididymoorchitis in a child, usually it is ascending infection from the urinary tract via the vas deferens into the epididymis, giving rise to infection. So if urine definitely shows presence of pus cells, then it is because of the the epididymoorchitis can be because of urinary infection. And color Doppler to look for the blood supply of the epididymis and the testes. Now, it is very difficult to differentiate between the two, even on color Doppler sometimes, and one may need to do scrotal exploration as early as possible. Delaying the surgery means losing the testes. Sometimes you may do negative exploration, meaning that there may be epididymoorchitis, but you operate so that you prevent the complication of torsion. Now, this was in an undescended testis. So there was a swelling, there was no testis seen in the scrotum, and there was acute swelling in the groin. So this child was operated with diagnosis of torsion, and we found the torsion which was resected. The another important thing is once the child is on one side torsion, the chance of developing torsion on other side is quite high because of the anatomical problem which has given rise to torsion. It is known as Bell-Clapper deformity. So if it is there on one side, it is there on other side. So you need to fix the opposite side. So we take out one side if it is black. If it is not black, if we can save the testes, we will unrotate and fix it, go to the other side and fix that also. So this was my presentation. I thank you everybody for patient listening. If there are questions, I will be happy to answer.
Thank you, Dr. Rasik Shah, for the wonderful talk. I would now ask Dr. Kamlesh Shah to introduce Dr. Pankaj Parekh and Dr. Jitesh Mehta, Dr. Yogesh Shah, Dr. Usha Shah, Dr. Bhavesh Shah, colleagues from the D ward to come forward, and we'll start with the next presentation. We'll have the question and answer sessions together at the end.
One sec, I need to share the slide of Dr. Yeah.
Yeah, perfect. Yeah.
Dr. Kamlesh Shah, unmute yourself.
Hello, good afternoon, everybody. It is my pleasant duty to introduce our own Dr. Pankaj Parekh. Dr. Pankaj Parekh is a consultant with the Pediatric Department of Sir H.N. Hospital, Reliance Foundation Hospital and Research Center. He completed MD Pediatrics from Topiwala National Medical College and Nair Hospital, and thereafter pursued Diploma in Child Health, DCH. Dr. Parekh is a leading pediatrician in South Mumbai. He is in private practice since 1978. Earlier, he worked at Kasturba Hospital in Infectious Disease Development Department as Assistant Honorary and at Nair Hospital, Assistant Professor of Pediatrics. Later, he served in the capacity Head of Department of Pediatrics at TNMC and as Professor of Pediatrics at TNMC and Nair Hospital from 1991 to 2001. Dr. Parekh joined Sir H.N. Hospital and Research Center in 1987 as Honorary Pediatrician. He is also associated with Saifi Hospital and Bhatia General Hospital as Honorary Pediatrician. Dr. Parekh was also Pediatrician to the Household of His Excellency, Governor of Maharashtra in 1980. Dr. Parekh has published many papers in reputed journals. He has written a chapter on measles in textbook of medicine as well as on pediatric tuberculosis in a book on thoracic surgery from UK. Amongst his various achievements, he has been the recipient of Indumati Javeri's Prize, a gold medal, for standing first in DCH examination. Over 37 years, he has been extensively involved in research and has written papers on various pediatric subspecialties. Additional specialty interests of Dr. Parekh are general pediatrics, pediatric infections, and vaccination and immunization. I invite Dr. Parekh and illuminate us on vaccinations and our day-to-day queries. Thank you.
Thank you, Dr. Kamlesh Shah. Am I audible easily?
Yes,
am I audible? Yeah?
Yes, yes.
Yeah. At the outset, thank you very much, Seaward Medical Association. In particular, Dr. Anil Mehta, Vijay Khambati, Jawahar Murtiyar. I will go through the immunizations and the important vaccinations today. Now, why it is important for all of us to know about the vaccinations? Because if you know the vaccinations well, probably you will be able to advise your patient more confidently. And you'll be able to explain them better the advantages and the side effects of the vaccination. In the first slide, I'm going to show you an immunizations table, what has been suggested by Indian Academy of Pediatrics. There are few changes what we have done in last few years as compared to the old vaccination schedule. The birth vaccines remain the same. If you see the 6 weeks vaccine, there are so many antigens to be covered. So we have multi-component or a combination vaccines. We will talk about that in a next slide. We also cover rotavirus and pneumococcal vaccine. 6 weeks, 10 weeks, and 14 weeks schedule is exactly same. At 6 months, in addition to hepatitis B third dose and oral polio, we give oral polio at birth at 6 months and 9 months, and injectable polio in 6 weeks, 10 weeks, 14 weeks, first booster and the second booster. So the polio is covered with 3 oral and 5 injectable polio doses. At 6 months, we have added influenza vaccine. At 7 months, for the first time when we give second dose of influenza vaccine. What we used to give only measles at 9 months is now replaced with MMR. Typhoid vaccine, which was an old vaccine, polysaccharide vaccine, which was given first time at 2 years of age, with typhoid conjugate vaccine, we immunize first dose at 12 months of age. At 15 months, of course, the second dose of MMR, a pneumococcal vaccine and chickenpox vaccine is administered first time. Next slide. 18 months vaccine is of course the first booster where we give hepatitis A vaccine, second dose. At 2 years, typhoid vaccine is given, so that once you give 1 year and 2 year typhoid conjugate vaccine, you don't have to give every 3 years vaccine, which we used to do in typhoid polysaccharide vaccine. At 5 years, we give sort of booster of MMR and chickenpox. But if you see, as far as the triple antigen is concerned, is only triple antigen combined with IPV. So we don't have hepatitis B here and we don't have HIV here, right? Similarly, if you notice at 18 months, in a combination vaccine, we don't have hepatitis B. We have HIV with IPV with DTP vaccination. And at 10 years, what you used to give only dual antigen TD is replaced with TDAM. And of course, we'll talk about HPV vaccine. Next slide. Now, this is about little combination vaccines before I explain. Now, you must remember that these combinations vaccines are given so that the less pricks are given to children, less number of visits. Now, I've given few names here so that you get used to the names. In a primary vaccination, we use either Infendix Hexazine or EZ6. Now, what is called as a reactogenic vaccine, which contains whole cell pertussis vaccine, and less reactogenic vaccine, which is acellular pertussis vaccine. If you read carefully, it is AP3, AP2. Now, what is AP3, AP2 means? Little bit knowledge about acellular pertussis vaccine. Normally, acellular pertussis vaccine can have up to 5 components. And these are pertussis toxoid, filamentous hemagglutinin, protecting, and fimbrial hemagglutinin type 2 and type 3. We don't get AP5 in India for a primary vaccination series. So we have AP3 and we have AP2. All the vaccines of GSK are AP2 in a primary series, while all the vaccines by Sanofi is AP3. Whether AP3 is advantageous over AP2 still remains little controversy. But the most important part in acellular pertussis is pertussis toxoid. Pertussis toxoid is a one thing, PT, which is highest immunogenic. Difference between AP2 and AP3 is presence of protecting. Protecting is a protein in the outer membrane, which mediates the attachment of Bordetella pertussis to the respiratory mucosa. So a component which is important, but not as important as pertussis toxoid. EZ6 has a wholesale pertussis, otherwise combination is same. A word about whether to use a acellular pertussis or a wholesale pertussis. Indian Academy of Pediatrics very strongly recommends wholesale pertussis for a primary vaccination, that is 6 weeks, 10 weeks, and 14 weeks of age. The reason is that both the vaccines, acellular pertussis and wholesale pertussis, has the same immunogenicity to start with. But the reason given behind using WP is that the immunity does not last for a very long time with acellular pertussis. Now it is a very practical problem that people who have been using acellular pertussis vaccine, their parents don't like to take reactogenic vaccine, which makes the baby cry, which makes the baby's legs swollen up. The intake reduces. So now what to do in this situation? So there is one practical suggestion by Indian Academy of Pediatrics. Okay, out of primary series of 6, 10, and 14 weeks, at least one dose, preferably 14 weeks dose, should be with wholesale pertussis vaccine. The booster doses, I have again two choice: wholesale pertussis, acellular pertussis. Pentaxim is AP2, that means only 2 component vaccine, right? It is pertussis toxoid and filamentous hemagglutinin. Next slide, please. At 5 years, if you take combination, we have a tetraxim. That means you don't need HIV at this age, hepatitis B. Again, it is acellular pertussis 2 component. You can also have. Indian Academy of Pediatrics also says that first booster and the second booster, this 18 months and 5 years doses, you may use acellular pertussis, because as you go higher up in doses, age-wise, 18 months, 5 years, the reaction to the wholesale pertussis is much more as compared to the primary vaccination. So you may use tetraxim or pentaxim for 18 months and 5 years booster. Now, important to know about is Edacidian Boosters. So we give Tdap, tetanus, diphtheria, and pertussis. They are all small doses. Suppose the standard dose is 40 international units of tetanus. This is only 20 units. Standard is 30 units of diphtheria. This is only 2 units of diphtheria. Pertussis, which is 25 microgram in primary vaccination, is only 2.5 microgram. So definitely reactogenicity. Edacel is by Sanofi, Boostrix is by GSK, and both of them are AP5. It's the first time we use AP5 vaccine, where you have all the 5 components of acellular pertussis vaccine, and should be advised at only at 10 years and above. Tdap is not advocated as a first booster or a second booster. It can be used only at 10 years and afterwards. Then there are another combination vaccine available, Prairie Strata, MMRV. We give MMR at 9 months, 15 months, and 5 years, where MMR and chickenpox are given separately. A MMRV vaccine, which is a combination vaccine, is advocated only at 5 years of age, only at 5 years. All those who have missed hepatitis A and hepatitis B, there's a combination, is called as a Twinrix, which is 720 units of hepatitis A and 20 micrograms of hepatitis B. And of course, at 20 years onwards, you can use the dual antigen. There was a suggestion whether we can use Tdap, because epidemiologically, even adults can be the carrier of pertussis and can cause a spread of pertussis in infants and small children. So there was a suggestion, American Academy of Pediatrics have a proposition and even approved the use of Tdap even in adults. Indian Academy of Pediatrics does not approve it so far, because the Tdap is definitely more reactogenicity than TD, because all the vaccinations of DTP combination, the reactogenicity is only and mainly because of the pertussis component. So if you use Tdap, which is a pertussis component, at 20 years and 30 years, the reaction can be very high. And that's why so far, we use Tdap at 10 years and dual antigen at 20 years. May I have the next slide, please? Let's go through few of the vaccinations, little bit more information, more detail. Is there a vaccine against a swine flu? Not a problem now, but few years back, we had a problem. So what is a flu vaccine? Everybody talks about a flu vaccine now, because on WhatsApp you get messages, true or false, that even influenza vaccine, flu vaccines has little protection against coronavirus. I know of a few societies where everybody has taken a flu vaccine. Many parents come to ask about flu vaccine. So let us have little knowledge about the flu. Influenza is probably 3 types of viruses, A, B, and C. A virus is seen in adults mainly and also in animals. B virus is predominantly seen in human beings, but particularly in children. It causes milder disease and more present in the younger population. A can cause a severe disease and more prevalent in an older population. Influenza C is not much of a problem in human beings. It's usually seen in animals. Now, why influenza A virus? Now, we keep on talking about the flu. You got a flu, don't worry. Many of them even are influenza A. But then why suddenly influenza A became a swine flu? Now, there are mutations. You all know that viruses keep on undergoing mutations. We have heard about coronavirus is going under mutation 11 to 25 times. So there are 2 types of mutations we see, antigenic drift and antigenic shift. Now, antigenic drift is a very minor changes, which you see in influenza A and B. Antigenic shift is a major change, and you only see in influenza A virus. Now, when you have a simple influenza A virus going into antigenic shift, a major change, it can lead to pandemic. And that can cause havoc, very high morbidity, and even to a certain extent, mortality. Can I have the next slide, please? So we went to give vaccination. Now, I also would advocate all doctors to take flu vaccines once in a year. It's very, very important for all of us to take it. Now, when to take the vaccination? What is the best time to give vaccination in India? Now, there are the prevailing virus strains keep on changing, not that frequently, but they do change. So WHO has a surveillance. It gives a formula for virus in February in Northern Hemisphere, where India is, and they give information about the strain pattern in September in Southern Hemisphere. Now, the companies who manufacture flu vaccines take around 3 to 5 months to manufacture the vaccine. Now, if it is a same strains, there is no problem. But if the strains are different, then February to May is the usual time they take to make a new formula. So it is, if you only have to take the vaccine, it's best time to take vaccine is in first week of June before the monsoon starts. The vaccine has 2 strains of A and 1 strain of B. Now we have quadrivalent flu vaccine. We have 2 strains of A and 2 strains of B. There are 2 types of vaccine. One is a live vaccine and another we have a inactivated vaccine. Live vaccine is intranasal. We'll talk about, next slide, please. Can I have next slide, Rasibhai? These are viruses. Let's not go into detail. But what is more important, okay, there is a whole virus vaccine, split viron, and surface antigen. Except Agripal, which is Bennecia Biotech, which makes a surface antigen which contains surface protein, hemagglutinin and neuraminidase. All the vaccines available in India has a split viron. Wholesale virus nobody makes because it's a very reactogenic vaccine, and we would not like to use this vaccine frequently. So Vaxigrid, Influvac, Quadrivalent, there are so many vaccines now available with split viron, and there's the common formula. Next slide. This live attenuated vaccine was once made by Serum Institute, Nasovac. Next slide. I'll tell you a little bit more about live after this slide. Now, this is dosing schedule of a flu vaccine. I'm talking about inactivated vaccine, a split viron vaccine. The earliest age you can give flu vaccine is 6 months of age. Upper limit is a no limit. Any age can take this vaccine. From 6 months to 3 years of age, the dose is 0.25 ml. 3 years onwards, the dose is 0.5 ml. Now, if you use vaccine for the first time, say somebody comes at 2 years of age, somebody comes at 4 years of age. When they come for the first time from 6 months to 9 years of age, you require 2 doses at minimum 4 weeks interval. And then you can give once a year, 1 dose. 9 years onwards, you require only 1 dose, even if they come for the first time. By and large, flu vaccine does not have much side effect. It's very minimally reactogenic. But there are side effects like GBS, Guillain-Barré syndrome, and febrile seizure, particularly those children who are more prone to febrile seizure with a strong family history of febrile seizure. Next slide, please. Now, this is about live vaccine, which we had left behind, a Serum Institute vaccine. Only thing, it is an intranasal vaccine. Can be used only about 2 years of age. Now, if you see, the incidence of flu is also very high below 2 years. So that's why one of the reasons why this vaccine was not much favored. If you see the protection wise, probably it gives a better protection than injectable flu vaccine because it is intranasal. If you must have heard about, okay, there is some news about even corona vaccine to be given intranasal because this is the route of entry of virus in the body. So if you give a local protection, then it can benefit the patient to the highest. It is a quadrivalent vaccine, but again, it cannot be given above 50 years. Being a live vaccine cannot be given in a pregnant woman, and all the children with a severe respiratory problem like asthmatic patients or older patients with a chronic pulmonary cannot be given this influenza vaccine. Have the next slide, please. Let's go to rotavirus vaccine. I'm going to give a little glimpse of few important vaccines, particularly in this area. We all have been using rotavirus vaccine. Now, what is rotavirus? This virus looks like a wheel. It's first found out in Australia, and that's why it's called a rotavirus. 80% of the infection in infant, particularly less than 1 year, where the diarrhea can be detrimental. Few years back, diarrhea was the commonest cause of death in infancy. Now, of course, the respiratory infections have taken over. Thanks to vaccine, rather than more thanks to ORS. Now, if you see Indian data of 2013 of less than 5 years of age children, there were 47,000 deaths, 8,72,000 hospitalization, and more than 3.2 million OPD visits. We don't realize about this problem, how mammoth it is. But if you go to the periphery, where the hygiene is a big problem, the viral diarrheas and the death because of viral diarrhea is still significant. Next slide, please. Now, what is rotavirus? There are 7 subgroups of virus. Now, let's not go into detail, but the outer protein G and P are the main types of protein we have. Now, a viral outer membrane is VP4 and VP7. Now, when you see any rotavirus vaccine, they give you something like G1P8, G2P4. So what is all this? Now, out of these 2 cuspid proteins, VP4 and VP7, VP4 determines the P serotype and VP7 determines G serotype. So you have a G type 1, P type 8, G type 2, and P type 8. These are presentation of outer capsid protein, VP4 and VP7. Next slide. Now, what is important for us is to know about vaccine. After knowing that the rotavirus is a significant problem, so we have, these are the various vaccines available today. I've written with the name and a company so that you can associate yourself with these vaccines little quickly. You have human bovine monovalent live vaccine. These are called RV1. It's only monovalent. So in monovalent, we have 2, Rotatec and Rotasure. Rotatec, the volume is 0.5 ml, made by Bharat Biotech, and Rotasure volume is 0.5 ml, Abbott. Pentavalent vaccine contains G1, G2, G3, G4, and G9 types of rotavirus. It has got 2 major contributors. Rotacil, 2.5 ml is dose made by Serum Institute, and Rotatec 5 ml made by Merck. Now, why I'm talking about 0.5 ml and 2.5 ml? If you see, this is a part of a primary immunization. A small babies, it is very difficult to give them larger doses of them because they vomit out. And particularly if they don't agree to the test, they will immediately vomit out the dose. It was initially when the pentavalent vaccine came, the manufacturer said the larger the volume, larger part of the gut will be affected to protect. The multiplication of virus will be much more than a small volume vaccine. But now this is not true. All the vaccines are practically equally effective. The monovalent vaccine also, which contains only 1 serotype, also can have a significant protection against all the prevalent type of rotaviruses in India. Every country has a different prevalence of rotavirus type. Even India, South and North, is a different. But all these vaccines cover all of them. It prevents 55 to 65% of rotavirus illnesses, hospitalization, and significant reduction in mortality. Next slide, please. Now, when to start and when to stop? Now, we start at 6 weeks of age. If you give monovalent vaccine, you can give 2 doses 4 weeks apart, either 6 and 10 weeks. Some study says 10 weeks and 14 weeks of age gives a better immunity. If you give pentavalent vaccine, then you give 3 doses 4 weeks apart at 6 weeks, 10 weeks, and 14 weeks. The contraindications is particularly you must know the age when to start, and when you can stop. I'll tell you in the next slide. But history of interception, which is very important, is absolute contraindication to any of the rotavirus vaccine. And of course, this being a live vaccine, severe combined immunodeficiency is absolute contraindication. Next slide. Now, what is catch-up vaccination? Now, maximum age for the first dose is 14 weeks and 6 days. That is 3.5 months and 6 days. If you have to start first dose at 15 weeks, you cannot start. So you have to give the first dose before 14 weeks and 6 days, and maximum age for the final dose is 8 months. So suppose you have started late and somebody has missed, and she comes at 8.5 months, you can't give the last dose of rotavirus. The reason behind this, the chances of interception is very high. The rationale is that by the time the Peyer's patch is developed, and rotavirus can cause enlargement of Peyer's patches and initiate the interception. Next slide, please. Rasik bhai, next slide. Let's talk about a pneumococcal vaccine. I'd like to cover few important vaccine. Why pneumococcal vaccine is important? Particularly whenever there is a viral epidemic, which is a predilection for respiratory system. The previous slide, please. Which is a predilection for respiratory system, pneumococcal vaccine is very important. Can I have the previous slide? Rasik, can I have a previous slide, please?
I am trying. There was little problem.
No, forget about it. Forget about it. Now, pneumococcal disease is important because there is a pneumococcal disease. No, don't worry about it.
Okay.
You have a pneumococcal disease and you have pneumococcal invasive disease. Now, a simple pneumonia, simple pharyngitis, simple otitis media is a pneumococcal disease. Pneumococcal invasive disease is severe lung infection like lung abscess, empyema. And what is more important in pneumococcal invasive disease is pneumococcal meningitis. If you see in infancy, there are 3 organisms which are common to cause meningitis: Streptococci, pneumococci, and H. influenza. Now, overall, all over the world, with the susceptibility of pneumococci also, with a penicillin and penicillin group of drug, the pneumococcal meningitis is the highest mortality. Probably the virulence of the pneumococcus is very high and the disease spread is very fast. 25 to 30% of a pneumococcal, invasive disease of the lung, and around 30% of meningitis are caused by pneumococcus. So pneumococcus is something which we worry about, and this needs to be protection. Now, before I start this vaccine, it is very, very important to not only emphasize importance of pneumococcal vaccine to the patient, because the cost is inhibitory, but it is also important that all of you, and particularly all the doctors who are above 50 years of age, must take one pneumococcal conjugate vaccine. In my previous lectures also I have told that this very often we neglect ourselves. And this is a one vaccine preventable disease which all adults, particularly above 50 years of age, must take. What you require only one dose of pneumococcal conjugate vaccine. There are 2 types of vaccine. One is a polysaccharide vaccine, PPSV23, and one is a pneumococcal conjugate vaccine. Next slide, please. Now, pneumococcal polysaccharide vaccine is a 23-valent vaccine. There are around 90 types of pneumococci, but this PPSV23 covers 80% of the serotypes associated with severe disease. 80%. But still it is not very popular. And one important sentence which I must say at this place: you cannot use pneumococcal polysaccharide vaccine alone to prevent pneumococcal disease. It has to be with pneumococcal conjugate vaccine. Alone pneumococcal polysaccharide vaccine can never protect, because it's a polysaccharide vaccine. It is T-cell independent, so there is no memory. You have to give them again and again. Poorly immunogenic in children, you can't give below 2 years of age. It does not reduce carry state, does not reduce herd immunity. And if you give repeatedly these doses, there is a hyporesponsive phenomena. So you can't give more than 2 doses of this particular polysaccharide vaccine. If you think of a typhoid polysaccharide vaccine, before TCV was available, We used to give every 3 years, and still it did not cause much hyporesponsiveness. But pneumococcal polysaccharide, if given more than 2 doses, the response is very, very poor with the 3rd or 4th dose. Next slide, please. Now, this is a quick picture how pneumococcal conjugate vaccine developed. We can have next. There are 3 things in this. Yeah, one more, please. Right. Now, when Prevenar 7 came initially, it had only 7 types of pneumococcal, as you can see. Then Prevenar 10 came, where type 1, 5, and 7F was added. And then Prevenar 13 came, where 3, 6A, and 19A was included. Now, why it is important to increase this number? It is not by increasing number that you are trying to show off, but it is because the people have found particular subtypes of pneumococci causing more problem. As for example, we have covered 3, 6A, and 19A in Prevenar 3. Now, 13. Now, Prevenar, the type 3 of pneumococcus is very invasive disease. If it causes meningitis, the mortality is one of the highest mortality. While type 6A and 19A is notorious for getting resistant to the normal routine antibiotics. So, why pneumococcal vaccine is important? It not only prevents the severity of illness, but it also protects the patient from a resistant pneumococcal infection. Next slide, please. Yeah, we'll talk about, now these are few carrier proteins. I don't think so I will go much into detail of this, because but only to understand this, all those vaccines containing diphtheria toxoid and tetanus toxoid, and there are 3 components we usually use is DT, TT, and OMP. Now, those vaccines which contains diphtheria toxoid and tetanus toxoid as a protein conjugate, their first and second doses don't give much protection. It's only after 3rd dose they go to nearly 90%. While all those vaccines contains meningococcal outer membrane protein, they give protection of more than 65 to 70% from a first dose. But of course, after 3 doses, the protection by all the 3 types of vaccine is excellent. In conjugate vaccine, we have a Synflorix, which is 10 component, and there is a Prevenar, which is a 13 component. There are few vaccines in development where you will have a pneumococcal conjugate vaccine, which is 15 component, and even Pfizer is trying to make 20 component vaccine. So they want to cover as many, of course, these are as per the requirement of different parts of the world, depending on the prevalence of what type of pneumococci exists there. Next slide, please. This is a vaccine schedule of PCV 13A. I'm talking about only conjugate vaccine. We will mention about a polysaccharide PPSV 23 later on. Now, when you have PCV 13, that is, you can say Prevenar and Synflorix. Primary vaccination is 6, 10, 14 weeks, booster at 15 months, right? And that's it. You don't need further vaccination than that. Catch-up vaccination, if somebody has not taken between first time they are coming to you, and very often the people you want to give Prevenar, but looking at the financial aspect of it, if the child is very healthy, breastfed, we tell them to start after 6 months, that only 2 doses of 4 weeks apart go. And of course, 1 booster. If you start after 1 year up to 2 years, you require only 2 doses, 8 weeks apart. And you don't need any booster for that, obviously. And more than 2 years of age, you require single dose of Prevenar. But in Synflorix, in 6 to 12 months, it is same. But from 12 months till 5 years of age, 2 doses are enough of 8 weeks apart, but you require 2 doses and not 1 dose like you have in Prevenar after 2 years of age where you give single dose. So this is a catch-up vaccination schedule. May I have the next slide, please? This is a high-risk group. In a short, what is a high-risk group? High-risk group are those with the chronic diseases of the heart, lung, diabetes mellitus, cochlear implant, cerebrospinal flow leak, like CSF shunt somebody has put, or somebody with asplenia, or somebody with HIV, and various complement factor and B cell, T cell immunity deficit. These are all high risk group of people. It is in high risk group where you require a polysaccharide vaccine 23, right? Now, if a high risk patient comes between 2 and 6 years of age, and if he has taken 3 prior doses, suppose somebody is undergoing, simple example, splenectomy for hemolytic anemia. He comes at 5 years of age. You have to protect him from pneumococcal disease. So if he has taken 3 doses, give 1 dose of PCV. If he has taken less than 3 doses, then give 2 doses of Prevenar. I'm talking names so it becomes easy for you to get. So 2 doses at 8 weeks interval. If somebody comes at 10 years of age, is on anti-leukemic treatment, is in or in a long-term high steroid treatment, you require 1 dose of Prevenar 13. This is what I advocate to all of you also. So when do you use polysaccharide 23 valent? So it can be used only in children about 2 years of age. First dose has to be given because it is a very wide coverage of 23 valent. So first dose of 1 dose has to be given 8 weeks after the Prevenar. And there's 1 more dose required in such immunocompromised patient after 5 years of age. But you can give only 2 doses, as I said previously. Next slide, please. I'll quickly go through. This is the last vaccine I'm covering, looking at the time constraint. This HPV vaccine, I think all of us must know. When Prevenar came in the market, everybody felt so expensive, how to give, and now Prevenar is given quite frequently. If you go little many years back, MMR also was not accepted that easily. Similarly, HPV vaccine is very important. It's the second most common cancer in a female after breast cancer, and it is the only cancer which can be prevented with the vaccine. Human papilloma virus is a majorly responsible for cervical cancer, for vulval cancer, and many other cancers. The important thing is HPV infection is very common. It's like you can compare with H. pylori of the stomach. It's very common. You can say practically all those who have sexual contact had sometimes HPV infection, but most of the infections are transient and benign. Only certain carcinogenic strains cause a problem. And that too also from infection to cancer, the time period is 15 to 20 years. Next slide, please. Now, 99.7% of the cervical cancer and more than 90% have HPV. So you can imagine type 16 and 18, and particularly type 16 is predominantly responsible. But there is a type 6 and 11, which don't cause malignancy, but they are non-oncogenic, and they are 90% responsible for anogenital warts and recurrent respiratory papillomatosis. Next slide, please. There are 2 vaccines available, quadrivalent and bivalent vaccine, and both are made by recombinant technology. I'll give the name again here so that it becomes easy for you to imagine. Quadrivalent is Gardasil, bivalent is Cervarix. And they both produce virus-like particle, which is L1, major protein of HPV. Next slide, please. The quadrivalent vaccine is 16, 18, 6, and 11. So it covers precancerous condition, cancerous condition, anogenital wart, and respiratory papillomatosis. And 3 doses. When you use a quadrivalent vaccine, you require 3 doses at 0, 2 months from the first dose, 6 months from the first dose. Efficacy is 99%, right? These doses are only now 2 doses if you give before 15 years of age. Earliest age is 9 years. If you give between 9 and 15 years, there are only 2 doses at 6 months interval. This vaccine given so far, as per the advocation of manufacturers, vaccine can be given up to 46 years of the age. Next slide, please. But this vaccine is very effective against vaginal neoplasm, vulvar neoplasm, very much less side effect. Both these vaccines, next slide please. Both these vaccines never have to be given in a standing position. Rasik, can I have next slide? Can never be given in a standing position. You should either make the patient lie down or sit. You should give a deltoid. This vaccine can cause syncopal attack after the vaccination. So all the patients who take this vaccine have to be made to sit in the waiting room for minimum of 15 minutes after the vaccination. Bivalent vaccine is 16 and 18. The manufacturer claimed this vaccine to be superior vaccine because of the adjuvant, which is ASO4. And they say because of this adjuvant, the immunogenicity of this vaccine is very, very high. If you use bivalent vaccine, it should be given to 0 month, 1 month after the first dose, 6 months after the second dose. Efficacy, statistically not much difference. Local side effects, systemic side effects are more or less same. Next slide. The recommendation is vaccines are 100% protection against cervical cancer. But very important for ladies about 30 years of age, where you require a periodic screening, Pap smear, this vaccine is not a replacement for a Pap smear. Pap smear has to go on. And as I said, both the vaccines are equally effective. Next slide, please. This is the schedule. 0.5 intramuscularly. If you give between 9 months to 15 years of age, 2 doses at 6 months, otherwise 0, 2 and 6 or 0, 1 and 6. Maximum age permitted so far is 46 years. Next slide. This also we have discussed. Next slide, please. There are 1 or 2 slides left. This also I have already talked, can never to give in a standing point. Now these are last 2 slides, which is very important. And last slide, a catch-up and adolescent immunization. Now this vaccine, this picture you must keep with you. All of you may take picture of this because there are many children who have missed the doses initially, have to be given catch-up, and particularly in adolescent immunization. MMR and varicella, if not given in the past, you require 2 doses at minimum 4 weeks interval. It may be 4 to 8 weeks interval. Hepatitis B, all the patient above 18 years, 1440 units at 0, 1 and 6 months. Hepatitis A, if not given to a patient before, 1 dose, because live vaccines of hepatitis are only 1 dose they advocate, but the killed vaccines are 2 doses at 0 months and 6 months from the first. Many people feel that if you do anti-HIV IgG, it may be cost effective and might prevent the cost of vaccination. Typhoid, always use TCV, don't use polysaccharide vaccine. 1 dose is enough. For anybody who has not taken 1 dose is enough. Now, tetanus, diphtheria and pertussis, somebody has missed triple completely. If they come between 2 and 7 years of age, you can give Bronchial pertussis or acellular pertussis vaccine in the same schedule, 0 month, 1 month and 6 months. But if somebody comes after 7 years of age, then first dose should be TDAP, that is Adacel or Boostrix. But at 1 month and 6 months after that has to be dual antigen TD. You should not give TDAP all the 3 times. So after 7 years, for a catch-up vaccination, first TDAP, then TD and TD. HPV vaccine, as I said, 2 doses between 9 and 15, and after that 3 doses. Next slide, please. I think thank you very much. Thank you so much.
Thank you, Dr. Parekh. I apologize in the outset. I think there was a slight mix-up in the question-answer sessions. We will take the question-answer session with Dr. Shah first. Please start with the question and answer sessions. So Dr. Rasik Shah, Dr. Bharat Bhatt, Dr. Jahaka Cooper, and Dr. Suryakant will start first. Dr. Bharat Bhatt, unmute yourself.
Bharat, unmute karo.
Please unmute.
Not unmuted.
So far, there are no questions from the audience, but I only had one question for Dr. Rasik Shah, that in umbilical granuloma, and you said cauterization is the treatment, can a dermatologist address that, or it has to be exclusively by a pediatric surgeon?
See, I think the person who should treat any condition, he should be expert. The degree does not matter. If you go by examples, we had ENT surgeon who became neurosurgeon. So for minor issues, I think anybody treats a minor condition is okay, but medico-legally it may not be right. I'm not sure.
Okay.
When it is a granuloma, it needs a cauterization. It can be done by dermatologists. They have a hand cautery. They can do it. I don't think there is any contraindication for them to do it.
Okay.
Yeah. There were other questions on chat box. If you want, I can just go and answer that.
Yeah, please go ahead.
So one question by Dr. Paresh Joshi was not directly related to my presentation, but how to manage tongue tie. So tongue tie generally, yeah, you will see the tongue which is tied, means it's with the base or floor of the tongue, oral cavity, it is, and one cannot protrude the tongue. Once you can't protrude the tongue, it will not touch the lower lip or palate, and B, P, T, B, P, T, it is difficult to pronounce. So ideal treatment is you need to separate it before child starts speaking. And that is at the age of around 15 months, they start speaking. So you want to correct that before that. Now, some tongue tie, if they are mild, the child may speak well, but there is no guarantee to it. So if no one wants to take chance, better to take care of that. The second question was about phimosis, whether we should teach the parents about gentle retraction or rather retraction. So as I told you, if they are not gentle, if they do gently, it is still all right. If they are not gentle, and while pulling, if there are any fissures, that will heal with fibrosis and it may not be good idea. The third, so if you advise, we have to tell them gently, there should not be any bleeding. The third question was role of circumcision in urinary infection. So urinary infection, when it happens in a male child, even one infection, it means we need to investigate for any underlying problem like vesico-ureteric reflux, posterior urethral valve. If we find any underlying urogenital anomaly, we will take care of that. If not, then the circumcision should be done to prevent the second infection. One infection in urinary or one urinary infection means some nephrons in the kidney are getting damaged. So you don't want to have this repeatedly, and by doing circumcision, the chances of infection will go down. Another question was about hemangioma, how long to continue propranolol. So generally what we say, if I start finding that the size of the hemangioma which was rapidly increasing, it has started now curtailing, it has become small, and then you will see the grayish spot, which means that it is started involuting. And at this point, if you stop, it is all right. Or you may continue till it is completely over, which may take 6 months, 1 year, 2 years. Each individual, it would be different. Then another question was in reference to sclerosant for both umbilical granuloma as well as for lymphangioma. So umbilical granuloma, there are mild sclerosant like regular salt. If you use, there is a mild sclerosant, it may work. And somebody has tried in some place and they found good results. So at home they can use it, or you can apply even spirit, and even that is sclerosant. When it comes to lymphangioma, the milder sclerosant, when we did not have bleomycin and sodium tetradecyl sulfate, people had used water, regular water, sterile water, and even that is mild sclerosant. But today, with availability of bleomycin, sodium tetradecyl sulfate, and other sclerosant, the role of water has gone down. So these are few questions which I remember. There are probably
So
some.
there was one more about experience of using timolol eye drops locally for treatment of small hemangiomas.
Yeah, so this is a newer way of managing hemangioma, which I have not used personally, but there are papers where you find good results with that. So I think that, and it makes sense, instead of giving oral propranolol, applying on lesion and on hemangioma. And it has a good results, at least whatever I have read and published, but unfortunately I have not used in any of patients.
I think that should cover all the questions which we have
Only
got.
one question, sir. For lingual thyroid, what is the right age for the surgical correction?
I think lingual thyroid, we should operate at the time of diagnosis if it is beyond the age of 1 year. If it is younger than 1 year, if the child presents with the swelling which is large and if it is symptomatic, I will go ahead and operate. If it is asymptomatic, then we will not know about it. If they are symptomatic, I think best thing will be go ahead and operate it.
There is one question for Dr. Pankaj Parekh from Dr. Preeti Gagan. What is your final thought about acellular and whole cell vaccine for primary vaccination? What should we ideally do? Pankaj Parekh.
Ideally, I think I will do is give 14 weeks whole cell vaccine, 6 weeks, 10 weeks acellular pertussis, and 14 weeks one whole cell vaccine and boosters with acellular at 18 months and 5 years.
Thank you, sir.
Dr. Yogesh, are you asking?
Yeah.
Usha, you ask first. Usha.
Is there any way to help poor people or poor class for the vaccination, subsidized vaccination?
It didn't come clear. Can we have the question again?
Usha Ben, you should mute yourself.
Any cheaper vaccine for slum people or the lower middle class of people, beside what the BMC gives them in a private clinic, how we can help them?
I think BMC gives a wonderful schedule of vaccine, particularly when they've introduced pentavalent vaccine. I think it is wonderful to use. You can't go cheaper than that because manufacturing of this vaccine also cost, and all WP vaccine, wholesale pertussis vaccines are not expensive at all. And if you try and give them separately, you might save a non-significant amount of money, but the amount of visits and amount of pain, amount of pricks the child get is not.
That is there. And at least our C ward and D ward can help the poor people, or we can have some camp for them also.
Certainly.
Usha Ben, you please ask.
Yeah.
Yogesh, mute.
Sure.
Can Synflorix be used instead of Prevenar?
Certainly.
Are both equally effective?
Is only
because Prevenar is costly.
No, I agree. Synflorix on an average population with a normal thing can be used as effectively as Prevenar, and there's no doubt about it. You can use it is a conjugated vaccine. That extra 3-valent, I don't think so makes much difference. But all those children, I personally feel that are prematurely born or born with a small for gestational age, there are chances that they should be covered with a Prevenar 13. Otherwise, Synflorix is equally effective.
Okay, thank you.
Dr. Pankaj.
Sir, can I ask a small thing about the vaccine, flu vaccine?
Yes, sure.
Sir, it's a wonderful talk you gave about the vaccines. So now in the coming few months, it is going to be something like a winter, and lot of flu cases will come up. And now it is practically impossible to differentiate what is flu and what is COVID, and there is a total mix-up. So the flu vaccine becomes all the more important now because all the hospitals are full and they cannot differentiate that even at the outpatient clinic or in the hospital, what is flu and what is COVID, they cannot differentiate. So giving a flu vaccine becomes all the more important because to that extent the workload or the burden on the hospital reduces. So that is a great idea to give flu vaccine to kids as well as adults, to everyone, especially winter and the COVID season. And one point. And another I would like to clarify me, the quadrivalent flu and the trivalent flu is there. What exactly is the difference?
No, the quadrivalent flu is a two component of B type of flu virus and two component of A type of, and trivalent has two types of A and one type of B. There is a very marginal benefit because a B type of influenza virus is never virulent, never causes serious sickness. But as long as it does not increase the cost of vaccination, if given a choice, why not use a quadrivalent vaccine rather than trivalent vaccine?
Thank you, sir. Thank you.
Thank you, Dr. Parekh.
Dr. Parekh, one question.
We'll take.
Hello, can I ask a question?
Okay, go ahead.
Hello. Yeah. So, Dr. Parekh, you mentioned that all the newborns who come in, or the adults who are in close contact with the newborns, they need to take a TDAP vaccine. Is that a single shot or do they have to take multiple shots?
No. The TDAP vaccine, American Academy of Pediatrics has advised to be given even in adults. See, we give 10 years booster, then every 10 years you require one tetanus was the original thinking.
Right.
Instead of that, because there is some resurgence of pertussis in certain part of America, particularly California, and they find that a developed country has a 20 to 25% carrier rate of pertussis even in adults. They estimate in India we have 70 to 80% carrier stage of pertussis in adults. But Tdap vaccination, though it contains only 2.5 microgram content of pertussis antigen, is still reactogenic. So Indian Academy of Pediatrics today and government of here does not advocate Tdap for adults. What we advocate here is only Tdap for 10 years old child and no pertussis after that.
Okay, not for adults over here.
Jawahar, I wanted you to announce the next webinar of Friday. Would you do it, please?
Yes.
And I want one more question for Pankaj Bhai. Jawahar, please announce first. Yeah.
So this Friday we are having a webinar with Dr. Tushar Shah on domiciliary treatment of COVID, and we'll welcome all the audience here to participate in that webinar. It should be very informative on the treatment of COVID at home, especially related to home treatment. So ideally suited for all the general physicians listening in. Thank you.
Pankaj Bhai.
Yeah.
There is a lot of talk about MMR vaccine giving some protection in COVID for adults. Of course, this is an adult question, but do you have any comment on that?
No, we have a few loose talks like BCG giving protection in corona and MMR giving protection in adults. But these are very non-specific. The people who have thought about BCG vaccine protecting from corona, because BCG vaccine predominantly stimulates T-cell dependent immunity. Now,
I think some of those questions were very nicely answered by Dr. Tushar on Friday, because we are going to take some COVID questions also there. So one of Tushar Shah's favorite dialogue was, the Lijjat Papad will probably also help in COVID.
So MMR vaccine is a very non-specific vaccine, and of course it has a beautiful protection against all measles, mumps, and rubella. So there's no doubt. But there's nothing, no special protection given to any other virus.
Yeah. Thank you so much. Thank you so much. I will ask Dr. Nilang Shah to come forward and please give the vote of thanks.
Thank you, Jawahar Bhai. I have this very pleasant duty to perform on behalf of all the participating organizations. This webinar co-hosted by the Bombay Seaward Medical Association, the Bombay Medical Union, and we are pleased that this time the Reliance the hospital has joined us for the first time in a webinar after the lockdown, and so also as the Midtown Medico, and we are very happy about this. We are also happy that our previous partners, the D ward, the A ward, the FFPI, and the GPA have continued to be with us. We are very thankful to the speakers who have given us a very, very lucid and interesting talk on and have kept us engaged in a very interesting seminar. We thank Dr. Rahul Verma, Dr. Mahesh Balsekar, Dr. Rasik Patel, and Dr. Pankaj Parekh. And we also thank all those who have been tasked with introducing the speakers and the chairpersons who were there to raise questions on behalf of the audience, which has made this webinar a very interactive session. And last but not the least, I would like to thank all the participants who have made our efforts worth the while. Thank you very much once again.
One correction, it is Dr. Rasik Shah and not Rasik Patel.
Dr. Rasik Patel is my teacher.
Sorry,
I am humbled if you compare me with him.
Sorry, very sorry.
No problem.
Thank you everybody. It was pleasant, wonderful.
Thank you so much.
Thank you.
Congratulations to Dr. Vijay Khambati's team. Thank you.
Thank you, sir. Thank you so much. President GPA, President C-Ward. I'm its member for 25 years, and they always organize in the best possible. They are head and shoulder above the other associations.
Really enjoyed this webinar.
Thank
Very
you, sir. Thank you
interesting
so
and
much.
informative.
Thank you.
Thank you very much.
Thank you very much.
Thank you.
Thank you very much.
Vijay Khambati.